Thank you so much for being with us today, Dr. Kofi.
Good morning, good afternoon, and good evening for people around the world joining us today, March 28th, 2024, for the HITLAB Digital Health Symposium, Nourishing Hearts and Minds, Celebrating Nutrition and Reviewing Vive and HIMSS. It was a big month of March, and we have a lot of digital health evidence to share with you around the world about what is actually working and what is actually being adopted. And again, we don't say anything badly about folks. We just talk about the things that are actually working with folks to make sure that they are in the know about where the evidence is heading and what the adoption rates are looking like. We're going to lead off today at 11:05 a.m. Eastern Daylight Time in New York City around the innovation around healthcare supply chains. We're really lucky to have a couple of major leaders in supply chains. And we're going to have Bill Taranto and Randy Sobrami from New York Presbyterian, Bill Taranto from the Merck Global Fund there. And then we're going to have at 11:20 Dr. Glennis Mehra from NYU Biolabs, and she's going to be talking about elevating the healthcare experience and navigating the future of value-based care, which is a big part of what happened at Vive and HIMSS this month. And so that will be exciting to hear from her. And we'll be looking for the chat box. Again, we're one of the few sessions online, open, free to the public, where we open up our chat so that everyone around the world can meet each other. And again, we'd highly recommend you put your LinkedIn there and connect with me on LinkedIn as well if you have questions or comments about the flow. That's where I focus my efforts as on LinkedIn in terms of the message board there. And then we go into a lot of other sessions in the second half, and that's going to be a big part of what we talk about today. One thing to remember, that the Breakthrough One, BT1, which is a membership group for folks who want to be a part of the Breakthrough Alliance here in New York City, which consists of the founding members of New York City EDC, Merck Global Fund, Medidata, New York Presbyterian, Columbia Medical Center, Cornell, all the major medical centers, NYU in New York City, but also hundreds of other people around the world. So BT1 is a way for you to connect and hear what's happening in evidence, hear what's happening on adoption, share perspectives, share insights, and share evidence. That's really what we're all about at BT1. And again, today only we have this 15% off. And so click on the QR code or just join up there and hit hitlab.org to join there today. Next up, we have, again, on the second half hour, we have folks coming in from the HITLAB community. We have scientists coming in from Neurometrics and Nourished RX, again, because this is, again, Nutrition Month around the world. And then finally, we're going to be talking about venture and how venture was going, what was going on with venture and funding for startups in Vive, in HIMSS. And we're really happy to have Elizabeth Bailey coming in from RH Capital, one of the major venture funds in digital health. First up today, to lead off this March symposium, one of the folks who've really led the transformation of healthcare over the last 10 years, Bill Taranto from the Merck Global Health Innovation Fund, and one of the folks who helped build the supply chain, the digital supply chain in New York City and the New York metro area, Randy Sobrami. And very happy to have both of these folks here today. Handing the virtual microphone over to Bill. Bill.
Thank you, Stan. I appreciate it very much. And Randy, it is a pleasure to meet you today. As a recent fund that's been investing in supply chain the last couple of years, I am really excited to learn more about supply chain and your thoughts on what's happening. As we begin, though, I always like to start these out. We have an audience, of a lot of different types of people. So, Randy, can you tell the audience about your career journey from being, from where you started to becoming director of supply chain at New York Presbyterian Hospital?
Sure thing, Bill. I'll first start by saying it's a pleasure to be here, and it's a pleasure to talk about this intersection between technology and supply chain management that's becoming so relevant to everything we do, especially in the world of healthcare. So just some broad brushstrokes as to myself and my career journey at New York Presbyterian. So over 10 years in general in this world of supply chain management, 8 of which at New York Presbyterian. And when I look at my journey, I'll really break it into 2 buckets. The first 4 years were on the procurement and strategic side. So we can categorize that simply as the team that determines which vendor we transact with, we contract with, we price negotiate with, basically the vendors that we conduct business with. And then part of that arm is also maintaining those strong business structures and the strong business relationships, and as well some relationships with our customers, who in the healthcare world, it's interesting to describe as patients, but we'll use that. And then Bill, fast forward 2020, onset of the pandemic, my role shifted more into the supply chain operations side. So that in essence is, I'll describe it with just 2 buckets. The first being leading a team of 135 wonderful people who are responsible for all of the disposable supplies that are used throughout a major academic medical center. At a very simple level, you could think of that as PPE, Band-Aids, gauze. At a more complex level, you could think of that as pacemakers, surgical robots, all of the implants used in unique spine procedures. And we'll get into that as we talk about some trends. And, it's been a journey coming out of the pandemic, but I think the last thing I'll say about this journey, Bill, is that 2020, when everyone couldn't find ways to buy toilet paper, this word supply chain and supply chain management has become more top of mind. And I'm thrilled to see and thrilled to lead efforts to think about how we use technology. And really, we'll get into it more on the artificial intelligence and a little bit on Gen AI, how we utilize that to merely guide and ensure that patient care is patient-centered. So Bill, I'll stop there, but just to give everyone a little bit of an overview.
Well, thanks for a little bit about your career journey. So let's get into it, as you said. So how do you believe the integration of technology and AI and supply chain management can benefit healthcare organizations?
Sure. So Bill, I'll start with maybe just an overarching, I guess, an overarching split in how we're thinking about this term AI. So there's 2 buckets really from my perspective. There's what I'll call the traditional AI systems, and then now what I'll call these generative AI systems that are guiding supply chain management and how we think about patient-centered care. So let's just take a moment to describe both of those and understand what I mean. When I say traditional AI systems, I'm thinking more of your traditional analysis and automation. So what that could mean, for example, is using AI to drive predictions about whether it's demand forecasting or from a nutrition perspective, how much infant formula do we need within a month to care for this type of unique patient volume? Relatedly, we can talk about how we utilize AI to classify our spend data that we utilize to drive, whether it's economies of scale, reduce pricing negotiations, all of which, again, in a patient-centered world and in a hospital world where, for the most part, hospitals are operating at relatively slim margins, those types of savings drive extreme efficiencies, of which I'll certainly elaborate on further. Traditional AI systems can be used on the invoicing side to recognize and categorize invoices and ensure our vendor partners are paid more promptly and correctly. And then also, you can think of traditional AI systems on the supply chain side being used for things like policy compliance and ensuring that the right financial controls are in place. So that's the general lens of how I think about traditional AI systems. Now, getting into what I'll term the common term that everyone's hearing now, AGI, or generative AI systems. This is where you have these artifacts where information is being generated. So from the supply chain side, think about this. At New York Presbyterian, we have thousands of vendors, and every healthcare system every large healthcare system operates in the same way. Imagine a world where you can utilize AGI or generative AI systems to summarize, your quarterly business reviews or key information from those hundreds of meetings that you're having. Think about using AGI to upload portfolios of risk, and then asking AGI or asking your generative system to output risk considerations for the vendors that you will transact with. You could even, on the procurement side too, utilize this AGI technology to create RFPs that you would normally have an analyst do, but then that time can just be reallocated back to other tasks that are more patient-centered. And then I think the last thing I'll hit on, Bill, and then I'll summarize it, is we're evolving in how we think about knowledge management and scorecards that, at least from a hospital perspective, and I would argue too on the medical device side and even on the pharmaceutical side, and I'm sure you're at Merck, you can comment accordingly, or you're experts as well, that as we develop these scorecards about how our suppliers are performing, and we'll get into trends later, you simply have the ability now to have data that's entered or translated by these generative AI systems and can then give high-level executives like myself that need to know information summarized so consistently that you can then in real time, or as close to real time as possible, make patient-centered decisions. So, Bill, I think I'll leave it at, utilizing these traditional AI and generative AI systems to drive efficiencies, to reduce waste. We'll get into elements of resource allocation as well, but just around just general supplier management, which in turn leads to better patient care.
Okay, so thanks, Randy. So this next question is going to be kind of broad, so it'll probably be a pretty good long answer. But again, it's around AI. How might AI-powered solutions contribute to improving efficiency and optimizing resource allocation within the healthcare supply chain? So a little more specific about the resource allocation component of it.
Yeah, sure. So what I'll say, Bill, and to your point, it's a broad question. I'll try to be as succinct as possible. I think of this, I'll take it in three buckets: one around supply chain visibility, one around supplier management, and one around resource allocation. So with these types of AI tools, whether traditional or generative, think about, from my lens as a supply chain leader, and the ultimate goal is supplies to care for patients, and that spectrum is so wide. You could have the ability to track your orders, your shipments in real time, which allows for not just greater inventory management, but a greater identification of what the bottlenecks are. You have goods coming from all, in this era of globalization, you have widgets and goods coming from all across the world. Knowing where a product lies, whether in customs, in transit, at a port, is of vital importance in lean supply chains that most hospitals operate. Relatedly, you can use this visibility to track the supplier performance and, in this era now, proactively manage product back orders. I mean, I think it's no surprise to this audience and to yourself that think of it from the lens of you have a unique supply, and we'll get into this trend in a moment, that's needed for patient care that comes from a different part of the world. That reassurance you can provide to a physician that, hey, we had a recent complex case where, a groundbreaking spine procedure that was recently done in New York Presbyterian, where thousands of supplies were on site for this care, just in case it were needed. But being able to provide our physicians, for example, or our customers with this real-time information as to where things are, provides true assurance, and it's one less thing for that person to worry about as time goes on. So utilizing this visibility, to summarize, to forecast better, to manage inventory better, to manage routes and optimizing how things are transported. And then in the end, it's managing risk to ensure our patients are well cared for. And then Bill, just to hit on, I know we want to talk really about resource allocation, but I want to harp on how those four pillars just really connect to supplier management and ensuring that our suppliers are reliable, the goods are of high quality, and the right pricing is in place. But Bill, to your point, AI and utilizing it for resource allocation, it's essential, even in supply chain within hospitals. Think about how this world where we could have patient data, treatment protocols, and just other factors that could influence how we order our goods. Mm-hmm. So again, I'll come back to, we're talking about nutrition. I lead a hospital that's for women and newborns. Recently, I think everyone is aware that one of the major infant formula manufacturers had a significant recall on their products. But from my end, think about this world where, and we're moving towards it, we're not there just yet. We can utilize artificial intelligence to understand our patient volumes, our patient data, understand our patient expectations, in this case, parents who are expecting formula to care for their babies if they choose not to breastfeed, and kind of complementing that with the ability to analyze recall data, analyze other market trends from the other two major infant formula producers in the world. That could just help, for example, me as a supply chain leader understand from a research perspective how much staff is on site, at what time is that staffing on site, But to go further, utilizing AI to then understand how we resource our, to a different lens, our clinical staff. So it all goes hand in hand, Bill, about utilizing these types of trends and information to really drive resources to care for our patients, whether it's your frontline supply chain team member, whether it's your clinical nutritionist, whether it's your nurse. So I'll leave it there. I know there's a lot to digress on even further, but I think it's a good summary.
A very good answer. So, with all this technology, let's look ahead a little bit. What do you see as, some of the most significant trends or even challenges in healthcare supply chain management? And then do you think things like not just AI, but other technologies can play a role in addressing them?
Yeah, so Bill, I have four trends that I just want to touch on briefly. This first is around, and the short answer is yes, utilizing technology and AI as an enabler to guide these trends in the right direction. The first is around supply chain resilience. Everyone's favorite buzzword with supply chain now, which essentially means that you're able to maintain standard operations even in the face of a major disruption. I think I hit on earlier how we can utilize, and some companies are beginning to utilize technology, whether it's sensory data, whether it's artificial intelligence to interpret that, to have that real-time visibility to where your stuff is, to then utilize that to measure supplier performance and to measure demand patterns really will help to drive us to create more resilient supply chain. So supply chain resiliency is one theme and one challenge looking ahead. From a healthcare perspective now, I think we're moving more and more towards this era of personalized, I'll term it as personalized or precision medicine or precision healthcare. So for example, we have surgeons who are requesting custom stents that are utilized in their cases. And that type of process deviates from our standard supply chain where you could buy goods or supplies in bulk, and you have your traditional PO receiving processes. Now we engage with our physicians more to approve stents, to design stents, but as time goes on and this type of precision medicine increases, we'll have so significant amounts of data. And this is just one system. Imagine, 6,000 hospitals across the country? I don't even know the number around the world, but utilizing AI to translate that data to help make more informed decisions, to help manage these unique products and where they are and how they're used as well, will be of significant importance. And then, Bill, I'll hit on just two other quick ones because I know time is of the essence, but healthcare is a very regulated environment. Mm-hmm. And from a technology perspective, and I'll use artificial intelligence, machine learning, RPA, all those general terms, from a regulatory, from maintaining strong regulatory compliance is a significant trend. Recently the FDA, or maybe not so recently, had the Drug Supply Chain Security Act, which requires, and I'm going to summarize, like pharmaceutical organizations or drug manufacturers to really communicate where drugs are produced and handed off at every stage of the logistical process. I can't even fathom, maybe you can, or someone from work can come on in the future and describe how complex that process is, and then utilizing how we can utilize technology and AI to guide all of those layers is really important. And the last thing I'll say is just, we're moving rightfully so in this era of sustainability and environmental impact. So just how we utilize AI to translate data around transportation routes, which again ties to carbon emissions or just gas emissions, packaging to reduce waste, and then just even facilitating the circular economy where supplies can be recycled properly and then reused for patient care. So I think, Bill, I'll leave it at, in the end, these trends of resiliency, personalized medicine, regulatory compliance, and sustainability just ensure that not only are we delivering the proper care, but we're just delivering safe care.
Great answer, Randy. Appreciate it. So we only have time for one last question, and I always like to end it around HITLAB and the Breakthrough Alliance. I'm just curious about, what's your involvement been with HITLAB and the Breakthrough Alliance?
Yes, so I will end by thanking Stan and the HITLAB team for continuing to invite me back to speak about what I'm very passionate about, and I hope my explanations have come across in this way about supply chain management and its intersection in this world of digital footprints and artificial intelligence. But I'm a proud speaker of HITLAB. I believe in its mission and vision, and the way in which the Breakthrough Alliance is trying to foster expertise within startups or growing organizations, but also just the resources that the Breakthrough Alliance offers. So I think this is my kind way of saying I'm happy to speak with this HITLAB community, because I think pooling experts such as yourself, Bill, and others who are listening is the only way we're going to advance. New York Presbyterian, I'll end by saying, has been around since before this country was founded. That doesn't mean we have all of the answers to solve all of these questions. We need to lean on this ecosystem of organizations that are in their first year of founding, or organizations that are in their 290th year of founding, whatever the math adds up to. So, no, it's a pleasure to speak here today, and it's a pleasure to see the progress that HITLAB has made. Bill, thank you. It's always wonderful to speak to you.
Thank you, Randy. I learned a lot, actually, which will help inform us in the way we're thinking about supply chain. And with that, Stan, I'll hand it back over to you.
Stan, we're having trouble hearing you. I'm happy to take over here for a brief moment. I think Stan's having some audio issues. So I'll just quickly come on here really quick. I just wanted to let everyone know that we have our New York City Health Innovation Week that is coming up in May. And we're actually having a discount code right now for the first 100 startups. To apply, we'll actually save $2,000 on tickets. So the link will be in the chat for that if you're interested. And then we'll just move right along here to our next guest. Thank you so much, Dr. Glynis, for being here today. She's the director of New York Biolabs at New York Lagoon. So I'll hand it off to you.
Hi, thank you. Morning, everybody. Thank you to the HITLAB team and Stan for having me. I'm really happy to be here today. I've spoken previously about value-based care in my past life. I did a lot of work around innovation translation in the healthcare system and disease interception, and actually bringing about robust outcomes for patients that were lasting. So with that, I would love to share my screen here and begin. Okay, so hopefully my screen is clear for everybody. So as many of you on the call know, that value-based care is something that has received quite a bit of support from the government and healthcare systems, and its impact both financially and on the health of patients has been well documented over the past 10, 15 years and beyond. There are significant programs that the federal government has put in place to test and iterate on the incentive models for value-based care. I will not go into those today, but I wanted to talk more and give an overview of the background and the context in which we're operating as innovators and supporters and influencers of innovation within the healthcare ecosystem as it's navigating this new horizon. So traditionally, we have a fee-for-service, and that fee-for-service model has worked in this country for many, many years, and it's primarily incentivizing volume. It's driven by volume. Every patient that's treated is an opportunity for reimbursement, for revenue. The value-based model is very different in that there's an incentive based on the preferences, the outcomes, and the quality that the patient experiences and also perceives. So some models for value-based care actually considers the patient's happiness and satisfaction with their experience with their physicians and care providers. And so that adds an interesting dynamic in which we are now at the forefront and able to actually deliver care in a more personal manner, in the sense where the patient actually matters and the patient influences the monetization and revenue generation. The ambition of value-based care is actually the ambition of the entire healthcare system from my point of view. So by being centered around patients, the patient satisfaction, the patient outcome, what we're doing is we have to align all of the components of our healthcare system and our innovation system in order to help patients and their providers and this ecosystem realize this goal. In essence, innovation is driving a lot of this. We've got payers, financial systems, we've got care models, quality and experience outcomes, leadership and governance, and also health information, and lots of data analytics that can enable this process and help us navigate. But at the end of the day, the structure of all of this comes down to stratification of patient populations. Traditionally, the traditional model of payments is one size fit all. There's a therapy, there's a standard of care that's applied across vast swaths of our population. Sometimes considering demographics, but for the most part, it is a one size fit all model. The beauty of value-based care and the challenge of value-based care is that we are moving more and more towards personalized medicine and stratification medicine. This isn't anything new. We've got lots of therapies, especially in therapeutic and drug discovery space, where stratification is actually essential for success. But value-based care has now made this more important. And I wanted to talk today about some of the challenges in that stratification. So overall, there are many challenges in implementing value-based care. There's the financial risk and unpredictability, because no one's guaranteed, regardless of their effort, that the patient populations will improve. And so if incentives are tied to outcomes, there's no guarantee of that. And so there is significant risk. There's regulatory and policy uncertainty, as I mentioned earlier. There are tests and models that are being developed at many levels of the government and also with private payers on how this whole system is going to work and what are going to be the best standards of practice. There are resource constraints. Lots of clinics are now burdened for a variety of reasons coming off of the COVID pandemic, but also digitizing a lot of the workflows, and data that's required now is adding additional burden and limiting bandwidth. There's data interpretability, which I think has been discussed many times in these forums. And then there is just the challenges of technology and innovation adoption. In addition to all of those challenges, we have the perception, which is not listed here, of the patient as they're navigating this. The patient is going to be experiencing changes, and the providers have to help the patient navigate this new way of considering healthcare. Now, with all of these challenges, there are tremendous opportunities. There is the promise of driving health equity, which has been a challenge in the US healthcare system from its inception. There's the opportunity for more enhanced care coordination, more robust 360 view of a patient and their problems, not just looking at one particular indication, but a holistic view of an individual's health. Now, with that, looking at the holistic view of an individual's health, we need innovation, because the current methods that we have are not sufficient. That's very clear. We need digital tools, and I know there's a lot of mention of AI, and a lot of people are tired of AI, but there is a tremendous opportunity, and I believe we are on the verge of incredible things, incredible way of the public and our healthcare system engaging with digital innovation. And we can be part of the conversation that the larger culture is having around AI. So generally speaking, digital tools for value-based care come in many forms, but most of it is centered around improving workflows and stratifying patient cohorts and tailoring the therapeutic or the care to those particular patient cohorts, and also monitoring. So there is workflow optimization, there's data collection, there is patient user interfaces, and there's iteration tools for iteration and optimizing that are very much part of the value-based care ecosystem. There are many, many roles that digital tech can play, which many of you already are very well aware of. Top of mind is data analytics, artificial intelligence, price transparency, data warehousing, and population health management tools, because a lot of the payers are not just looking from an individual perspective, they're also looking from a population, because that's where the real value will come in. The main challenge to all of this, as I mentioned earlier, is that there is significant heterogeneity and multi-dimensional diversity. Traditionally, when we talk about diversity, you think of demographics, class, and race. And indeed, these disparities have been well documented. Women, for example, looking at this slide, have a 20%, actually, women report 20% issues with their providers in terms of communications. Black women, for example, are nearly 2 to 3 times more likely to experience mortality during childbirth. These disparities are very well documented. And in fact, the system that we will all be operating in is going to have to address this, as HHS and the federal level is very much focused on identifying drivers and incentivizing solutions. The issue with stratification and diversity, as we are currently discussing it, is that it's missing lots of aspects of diversity. Diversity and stratification can happen along many different lines. Biology is one that we're very familiar with in the therapeutic space. Social factors such as background, socioeconomic, geography, etc., have played numerous roles. However, there's one that I'd like to highlight, which is here, the psychological or psychoanalytical aspect, dynamic aspect of diversity. So there are differences in learning and memory, attitudes and beliefs, personalities, behaviors, emotions, lifestyle, etc., preferences. And so in the consumer product space, this type of stratification is well established and used. And I think those who are developing digital tools can benefit from looking at what's being done in the consumer product space around personalization and stratification on that psychographic level. An example of the benefits of personalization around this psychographic level can be seen here in this McKinsey summary of a McKinsey report. So looking at patients that were discharged and seeing their re-engagement and the cost of that re-engagement with the healthcare system, what you can clearly see is that there are preferences that patients have, but there are also different ways they engage and learn about how to manage their healthcare and make decisions. So in this example here, one patient does independent research that seems to drive their decreased in unplanned high care costs, whereas another patient who's actually doing independent research, which you think, oh, it would be a marker of better outcomes and increased compliance, is actually increasing the cost for the healthcare system. And so what you can see here is an opportunity to identify who would benefit more from particular types of education and particular type of engagement. So based on this report, I encourage those of you who haven't seen it to actually just dive into this. It's a wonderful McKinsey report about the impact of personalization and looking at dynamics of provider and patient engagement. Another example of this in which personalization can help, and I believe I presented this last year when I spoke at the HITLAB Symposium, is that when patients are engaged with their physician, there's a lot of psychology that's happening. And in that psychology, the patient is usually interpreting the provider, and the provider is interpreting the patient, and that interaction can actually fuel understanding by the patient of what they're supposed to do, what their indication is, and actually foster or disengage their level of willingness to participate in the healthcare system. As you can see, it's something that I'm tiptoeing around, but this is one of the more, I think, contentious issues in which we think about implicit bias that is affecting how patients engage with their providers and with the healthcare system. And so by being able to monitor and segment the performance, the style of those interactions, we could actually create training programs and iterate on better engagement and better outcomes. So to wrap things up, there are some basic key strategies to employ. As I mentioned, this is just a very robust, not robust or brief overview of value-based care. And in essence, what we need to do is think about the challenges for the providers, but also the challenges for the patients. So for the providers and for the systems, it's implementing cost-cutting measures, implementing processes that works for their team, that actually improves engagement in terms of the employees wanting to be part of the value-based care system, and also improving the patient's outcomes and the patient's notice and recognition of the care that's being provided for them, and their subsequent, I guess, adoption of recommendations by their care providers. And with that, sorry, rushing through this, I'd like to thank you all, and let's please meet patients where they are, and happy to continue the conversation.
Well done. And again, for folks who are not familiar with what happened at Vive and HIMSS, this conversation was one of the top three. Obviously, AI was dominating, and certainly patient centricity is always dominating these meetings, but value-based care and that model, and as it's growing, was also dominating. Glenys, thank you very much for such a wonderful presentation.
Yeah, thank you.
And it's and again, we encourage everyone on the program today to use the chat box to keep in touch. I popped in my LinkedIn in there as well. So if you do have any comments, questions, topics, or future speaker recommendations, message me on LinkedIn. Let me know as soon as possible so that we can get those going. And don't forget to, if you know an institution or an enterprise who would fit well with the Breakthrough Alliance, then please let us know. We would love to have them join this effort to really make sure that the technologies that can really help patients, the ones who have been evidenced, those ones that have been evidenced out to the nth degree, are able to join. And you can join folks like Glenys, of course, Bill Taranto, Laurent van der Leberg, who's recently retired Chief Strategy Officer from Sanofi, and Michael Peterson, who's one of the leaders in technology and supply chain technology globally for the last 30 years on that board. And we'd love to see you there. Next up, we have a tremendous opportunity to hear more about what's happening within the ecosystem from Lauren Driscoll and our own Jerry Antamano, and talking about revolutionizing healthcare and what Nourished RX is doing in that area. Handing the virtual podium over to Jerry.
Yeah, cheers, Dan. Thanks so much. And it's wonderful to be back on the program to be able to talk to some of these wonderful change makers who are really making a difference with their different solutions within the ecosystem, and not least of all, Lauren Driscoll, who's joining me today from Nourished RX, a really wonderful organization that's providing highly personalized food solutions for both health plan and providers to the most vulnerable members of the community. But I'd love to welcome you, Lauren, to the program, and would love to get you to introduce yourself for a quick 60 seconds to let everybody know that's in the audience about yourself and what you do at NourishedRx.
Perfect. Thank you so much, Jerry, and Stan, thank you for having me today. So my name is Lauren Driscoll, and I'm the founder and CEO of NourishedRx. And my background is really across a number of different healthcare settings. I've worked in policy settings, I've worked in managed care. I ran the Medicare business for Oxford Health Plans before it was bought by United. And then after the Affordable Care Act passed, I worked with Governor Mike Leavitt, who'd been Secretary of Health and Human Services at Leavitt Partners. And after he left DC, he started Leavitt Partners to really help private sector companies navigate the Affordable Care Act and, in particular, value-based care. But the common thread throughout all of that experience is, and across those different settings, has really been a focus on vulnerable populations. And I come at that both from a values standpoint, and that clearly, you want to support the people who need it the most, and also from really a healthcare reform standpoint, really wanting to drive better outcomes, more equity, and more efficiently at a lower cost. And I've just, as a result of a focus there, I've had a long time focus on the social drivers of health, and in particular, just in the importance of nutrition and food access. And I've had, long held conviction that we as a country have really nutrition and food access has just been a glaring missed opportunity when it comes to healthcare delivery. So took the plunge in 2019, actually with the support of the Health Policy and Management Department at Mailman, and started NourishedRx.
No, that's really wonderful, and I think it's a really great time to be able to making that kind to make that kind of impact in the communities today. But I'd like to take it back to sort of the really sort of basic concept of food as medicine, which I think everybody on the call today can really relate to, and how that's evolved over time, and the factors that have influenced the trajectory in modern healthcare practices.
Yeah, for sure. So I would say when I was first setting out to start NourishedRx, I assessed the landscape with respect to nutrition and food access. And to be honest, food as medicine wasn't even a common term at that point in 2019. And what I saw was really a number of different point solutions. I mean, you had medically tailored meals, certainly some produce prescriptions, definitely amazing work being done by food banks, food assistants. But really, they were all pretty siloed, and at least on the medically tailored meal side, very, very much fee for service. And I think what's happened just over the last 4 to 5 years is, obviously COVID shined a bright light on health disparities, and nutrition is such a root cause of health disparities. I think COVID also, really brought about much more home delivery of prepared meals and meal kits. And so there was just more agility really in the food system to actually get food to people and have them select what they're eating at home. But I think really with the progression of value-based care, in addition, what we have recognized as a company is that as opposed to delivering point solutions that are sort of food as medicine related in silos, if you're addressing really the people who need the help the most and are costing our system the most, it's important to have a broad tool belt to be able to provide a comprehensive solution. So across all of those point solutions. So I think increasingly you're seeing more of a value-based care approach where, we're delivering really a bundle of nutrition and food access related services in a personalized way to really be able to optimize outcomes.
Yeah, no, absolutely. Yeah. And I think, COVID definitely did change the face of how we see sort of nutrition with, you know, all of these different sort of services, as you mentioned, sort of coming into the into the communities, and none less so, of course, than what you're doing right now with NourishedRx. And I think we'd love to hear a little bit more about the approach that you guys are taking to integrating food as medicine into, you know, into the healthcare model, and how does it sort of differ from sort of the more traditional approaches?
Right. So we really don't think of ourselves as a food delivery company. We very much are a healthcare company, and our leadership team is, you know, all steeped in healthcare. And so as such, it's very important to us to be clinically integrated and really an extension of care and disease management programs. And also to really systematically measure as we work with members longitudinally. But really, to take a step back, we consider ourselves very much an integrator. So we have a modern and configurable technology stack that enables us to integrate with an array of point solutions. So prepared meals, produce and groceries, even fintech solutions addressing food access, telenutrition counseling, an app, you know, healthy eating app, obesity telehealth, even community-based resources. So we're that really technology backbone that's integrating all of those different point solutions. And then on top of that, because we really are targeting folks who are nutrition insecure, who also have diet-related disease like heart failure, diabetes, kidney disease. We also do maternal health. There are additional resources or capabilities beyond those that we integrate with that we have really built on top of our platform. And so part of that is integrating a very diverse food network so that we can be genuinely culturally responsive and really meet people where they are with respect to their taste preferences. A very broad array of educational resources that are available through an omni-channel experience. So, you know, if people don't have access to technology or a degree of comfort with technology, we can connect through simple text, email, app, but also telephonically. And then also the ability to connect people to community-based resources so that they're able to, you know, continue to navigate their own food landscape optimally. And then I guess the last thing I would say is we were built on a FHIR-based platform so that we can be fully interoperable with our healthcare payer partners and provider partners.
No, that's really, really wonderful, Lauren. Thanks. Thanks so much for giving us such a really detailed overview about the brilliant work that you guys are doing. I'm so sorry we don't have more time to cover all the other points you really wanted to make, but we did put your details into the chat so people can connect with you that are really interested about the work that you're doing. And you know, I'd like to thank you so much for coming on the program, albeit for a very short conversation. But hopefully you can continue talking about the great work that you're doing and the communities that you are serving via NourishedRx with the audience here today.
Great. Thank you so much. Really appreciate it.
Thanks so much,
Take
Lauren.
care. Bye-bye.
Sam, back to you.
Jerry, thank you for that great interview. And you know, one of the things that we saw today was another company that's focusing on nutrition getting a $30 million raise finished off yesterday. So that press release came out, and you know, we're seeing the funding community looking at the stock market crossing over 40,000 the other day. We're now seeing the funding community around digital health really coming back alive and funding, especially groups with track records, groups with revenue, that sort of thing. You know, funding the ABC rounds, and then we're also seeing that the folks who have the bandwidth and have the capability on the angel side are also getting a lot of funding. Angels write checks more like what you see with consumers using credit cards. Angels are much more bullish. Angels being predominantly physicians and healthcare executives who've done well over the years, and they want to contribute back into this this ecosystem. And we're seeing a very nice resonance of that kind of community building into the and really investing into the digital health ecosystem. So again, would love to see any comments or any ideas that you have on the chat box as well on that thesis. And that's just something that we've seen at HITLAB with a lot of the technologies that we're testing. We're seeing that they're taking a lot of our evidence and a lot of our testing data and getting angels interested in what they're doing and how they're doing it. One of the things we also want to talk about is the HTech Collaborative. We're always excited to work with the AARP, as we have over many years now, going back into the early 2000s, but more recently over the last few years, working with them on their incredible HTech Collaborative Challenge. For those of you who don't know about what AARP is doing with the HTech Collaborative, please look it up, take a look. And if you have a startup, and if it's something that can help folks who are over 50, please do apply. This is there's cash prizes, of course, the HITLAB Research Prize. So there's a number of very, very impressive people that are involved in this. I don't know how many of you folks have followed the symposium over the many months and joined the symposia for many of these, but we have a number of technologies who've been brought into the HTech Collaborative and done very well. The collaborative has an incredible group of support mechanisms, whether it's mentorships or whether it's introductions to buyers or whether it's really detailed research on the aging community. Just an incredible group of people, and always loved working with them. And then along those lines, we are now into the second half hour of the first of 3 hours of what we're building here today for the March Symposium around, again, a lot of the technologies like neurometrics. And so HITLAB's own Riley Fink, who's an innovation manager with our strategy practice, is going to be interviewing a couple of executives from neurometrics and learning more about what they're doing to improve equity in healthcare through digital technologies. Riley?
Thanks, Stan. And I believe that we are going to be joined by at least one member. Well, wait a second. Let them get everybody situated here.
Oops, can you hear me?
Yes, I can hear you. I can't see you though.
It's not letting me start the video here. Oh, let's see if that'll do. No. All right, so you want to do without video?
Sure, we can do an audio format. We'll pretend it's a podcast for this session here.
Right.
So, well, thanks for joining us at least audibly. Please give a brief 30-second introduction about yourself and some of the work that you're doing with neurometrics.
Hi, so my name is Jan Semzelius, and I'm originally from Sweden, lived for 4 decades in the US. I'm a graduate of Harvard Business School and ended up running startups since about year 2000. And we've been at neurometrics now for 12 years, and we're finally beginning to see some real interest in the market. All the stuff that's going on Alzheimer's is really helping.
Excellent. And can you describe a little bit about the product itself, what neurometrics does, how it works, how it can contribute?
Sure. So we stumbled on that typing cadence, the rhythm by which we all type on a keyboard, is by far the strongest habit that we have. There's nothing as consistent as this that a human body ever does. And originally we had that worked up for an authentication product. But then somebody said in a meeting that I bet you that can also be used to detect Alzheimer's. And that afternoon we pivoted. And so basically the way this works very simply is somebody who's going to be, it's based on the notion of that this is the strongest habit that we have, so it's really hardwired in our brains. And so if the brain is attacked by something, then the wiring will begin to break, but it'll break very slowly and in very small increments. But our tool is incredibly sensitive. We can see changes within a person to the tune of statistically significant changes to the tune of 1/100th of a second, which of course the person and the doctor would have absolutely no idea about. And it's very simple and user-friendly. The person gets an email from us or from a researcher or somebody else. And in there's a link, click on the link, and 2 more clicks, and the measurement has already begun. And we don't use any tests. It operates completely in the background, and after 15 minutes, they will highly likely have forgotten that it's even there. And then occasionally, then a file is sent to our server, and on the backside of the server, one can then see the charts, how this person is doing, and if anything has changed, etc. Riley, I think that'll do.
Yeah, that's incredible. I've heard of companies analyzing your typing patterns to look at productivity, but this is a unique way to look at typing and use it for improving access to healthcare. So specifically along the lines of our discussion today with health equity and access to healthcare, what is the cost generally to the patient, and how does it enhance the ability for people to get access to healthcare and overcome some of those financial barriers?
Our product is extremely low cost since it's basically only internet and software. And we're currently really focusing on pharma, but by the time we get to actually offering the product to individuals and through doctors, et cetera, we do have a reimbursement code that would let us charge $112 per year per person. And I think we'll do just fine for that. So we'll basically, the patients will not pay anything.
That's incredible. And unfortunately, we have just a short amount of time left. So what I would ask is, can you share a little bit about how this can improve remote patient monitoring? Obviously you just need software and a keyboard, and that technology is available across the areas where maybe they have less access to specialized care. So can you talk to me about some of those kind of novel use cases that you're looking to deploy, and how that can help promote access to healthcare in areas where it might be limited?
Sure. The healthcare system, in particular when it comes to neurological or psychiatric diseases, is really all based on getting the patient to the clinic, which in particular for neurological diseases is useless in most cases. Our data shows that 2/3 of people that were called into the clinic basically were doing just fine and didn't need to be there. And not only can this be difficult for certain people in some countries, like the one I'm in, people may have to travel hundreds of kilometers to get to the doctor. And so what is happening, because the lack of our tool, is basically that the doctors are spending most of their time on people that really don't need care, and certainly not enough time on the people that really need care. And so a doctor, for example, can make a change in the treatment to a patient, and then a couple of weeks later go into our system and conclude, did it work or didn't it? And if it didn't, okay, experiment in some other direction and send the patient an email about that, well, you're going to change your meds and so on, and then keep repeating until the patient is doing better.
That's incredible. My last question for you is all about privacy. So in a world where you're operating with data remotely, and certainly it's on the top of everyone's mind, what do you do to protect privacy and data security while people are utilizing your product kind of all over?
2 things. The first, and maybe foremost, is that we never know who the person is. So, we have no way of identifying who the person is. That's all going through somewhere else. Somebody else has a list of basically our user IDs, ID numbers, and who the person is, but we never have that. And the second thing is that so our software collects data related to typing, but before our software sends any data to our server, all the original timestamps are deleted, which basically means that the sequence of what was typed is now completely gone. And thus it cannot, and what was typed cannot be reconstructed because it's just looking like it's random data. Of course, it isn't. But if you remove the timestamps and you don't have any idea about what order what order the letters were coming, there's no way that you can tell what it was supposed to say, what it said in the first place.
That's incredible. Well, thank you very much for sharing a little bit about what you're doing, and we really appreciate learning about your product, and hopefully we'll hear more from you in the future. I'm going to hand it back over to Stan.
No, that's great, Riley. And again, Jan, thank you for your time today. And we're seeing a lot of neurotech really out there and seeing a lot of adoption of it. And we're looking forward to seeing a lot more from these folks. Don't forget as well, Breakthrough Alliance. These applications are open for the Breakthrough Alliance Challenge. We'd love to see your startup or your tech that you're particularly fond of applying to the Breakthrough Alliance. If you could share this with your community, let people know on LinkedIn. You'll see the LinkedIn post on the HITLAB LinkedIn page, and you can certainly share that through that as well. But just an amazing group of applications so far. Would love to see it expanded even further for the summit and the New York City Health Innovation Week presentations on May 6, 7, 8 at the Microsoft Tech Center. Next up, we have, again, our own Jerry Antamano, interviewing one of the leaders in the digital health investment ecosystem, Elizabeth Bailey, coming out of RH Capital, which is part of the RIA Ventures, which I think all of you should know by now, regular guests on our programs. And on that note, we're looking forward to hearing what Elizabeth has to say about forging forward in this environment. Handing it over to Jerry. Jerry?
Yeah, cheers, Dan. Thanks so much. With March being International Women's History Month, and having observed International Women's Day and Week earlier in the month, and those of you, of course, in my home country of England, celebrating Mother's Day this month as well, it's my pleasure to have Elizabeth Bailey on the program today. Of course, as Stan mentioned, with RH Capital, strong supporters of the HITLAB initiative, Women's Health Tech Initiative. And Elizabeth, wonderful to have you on the program. I know we don't have much time, but for those in the audience that aren't aware about the work that you do, and of course who you are, I'd love to invite you to just tell the audience a little bit about yourself and what you guys at RH Capital do.
Yeah, thanks so much, Jerry. I so appreciate HITLAB's programming, especially in the women's health space. So really glad to be here. I'm Elizabeth Bailey, co-founder and managing director of RH Capital. We are an early stage women's health venture capital fund, investing across the healthcare continuum. So we invest in life sciences, diagnostics, devices, and biotech, really all the way to digital health and tech-enabled services. I think according to the latest SVB report, we now have the largest portfolio in women's health. We've made 21 investments over the last 4 years and are continuing to invest out of our second fund, and are gearing up for a third fund later this year.
That's fantastic. And thanks so much for the work you guys are doing to really support our femtech founders, of course, within the space, and helping them really get their solutions out to where they're needed to really address these unmet needs for women. And you're getting a lot of love in the virtual reactions, a lot of virtual applause for the work that you guys are doing. But we'd love to know, as a women-led impact venture capital fund, as you mentioned, what criteria do you consider at RH Capital when you're selecting these early stage startups to invest in, and especially those, of course, that align with that mission of revolutionizing women's health?
Yeah, well, I would say that the entrepreneurs are really doing the heavy lifting. We're just here to support them and the amazing work that they're doing. So as you mentioned, impact is really important to us. So, we always get the question, what does that really mean? We have 4 impact pillars that really guide our investment strategy that are all centered around health equity. So first, we invest in things that are scientifically or clinically transformative versus incremental innovation, which is also important. But we're really looking for kind of game-changing innovations. We also look for companies that are expanding access to products and services, and we're particularly interested in serving underserved communities, whether that be geographically underserved, rural populations in the US, BIPOC communities or low income and Medicaid populations. And I would say relatedly, we look for things that address affordability. We want to make sure that there's reimbursement in place, or if products are direct to consumer, that they are affordable to all women and all women can afford them. And our fourth pillar, which, last but not least, we look for innovations that are addressing systemic change, where we know there are huge inequities. And in addition to product innovation, we want to work to change the system that we know is not serving women very well today.
Yeah, and I think really, really important criteria, really important identifiers to really make sure you're working, of course, rather than just selecting the right individuals and solutions to really help to drive the change within women's health. And I think especially those in the audience who are founders with these, who are creating some of these solutions right now, we'd love to hear a success story from one of your investments that really typifies the fund's bold approach, as you just described, to when investing in innovation and the impact that you just mentioned in terms of improving access and the quality and choice that's affordable sort of out there for women's health right now.
Yeah, so this is always a hard question for me, Jerry, because out of a portfolio of 21 companies, it's always hard to just pick one. But a company that we're particularly excited about these days is called Evie, which is a vaginal microbiome company. So Evie's a direct-to-consumer company providing telehealth and diagnostics around the vaginal microbiome. But through that D2C model, they have collected the largest data set of the vaginal microbiome. And so instead of, I think when we think about things that are game-changing and transformative, this is a company and a set of entrepreneurs that have said, we're not going to wait around for academia or industry to figure out this really important part of women's health, the vaginal microbiome. And instead, it's a group of entrepreneurs and women that are saying, we are gonna actually figure this out ourselves, which is incredibly inspiring. And what's been super interesting about a direct-to-consumer company is that they have a huge percentage of their customers that are opting in to use their data for research. And so I think while it's starting as a D2C company, the impact that they will have through this massive data set and through partnerships both on the diagnostics and therapeutic side, we think could literally revolutionize women's health.
No, that's really wonderful. I believe we've had Evie on the program of Women's Health at Wednesday at some point, I think much earlier in their stage of development.
Yeah.
And it's really wonderful to hear you guys are working with them now to really create that impact and of course share that story with the founders here who are going through that the same sort of challenges that they've been going through as well. I know we don't have too much time, and it is always really short and sweet in terms of the sessions we have. But before you go, we'd love to hear about, in the context of course, the Vive conference that just passed earlier on this year, about sort of the role that RH Capital envisions playing in fostering collaboration and innovation within the women's health ecosystem, of course, and the opportunities that you see for startups in the space to connect, of course, with the fund, which I think a lot of the founders on the call today will be really interested in hearing.
So what I will say coming out of the Vive conference and actually just looking at the space more generally right now is that 2024 is unequivocally the year of women's health. So our fund has been in operation for about a little over 4 years, and I have never seen so much interest, excitement, momentum, activity in the women's health space as I do today. So when you look at things like the White House Initiative on Women's Health, the hundreds of millions of dollars that are being dedicated to women's health, the growing investment that we're seeing from venture capital, what we need is innovation, and we need data, and we need women and men to continue to kind of amplify the unmet needs in women's health. It's going to take a village, but entrepreneurs are really at the heart of that village, and are a critical component to advancing women's health. So I guess my sort of my closing words would be reach out. I would love to learn about what you're doing and how you're shaping women's health. We are here to help in any way we can, certainly with funding, but also through connections and other types of expertise. And lastly, don't slow down in what you're doing. This is an incredible moment. And your work has never been more important. So, please keep on doing the amazing work that you're doing as entrepreneurs.
No, thank you so much, Elizabeth. Really, really sage advice, I think, to end with, and a really, really poignant point to make in terms of really giving some encouragement to those founders who are really making a difference and creating these solutions within the ecosystem. Elizabeth, thanks so much for coming on the program today. I really appreciate you being able to make the time to speak with us, and a massive virtual round of applause is coming in from the audience here. We put Elizabeth's contact details in terms of her LinkedIn and the link to the RH Capital website. So please do check them out, as Elizabeth mentioned, and do connect with her and RH Capital if you not only want to look at funding within women's health, but also just getting involved within women's health and the important work that they're doing. So thanks so much, Elizabeth.
Thanks so much, Jerry. Really appreciate it. And thank you to all that HITLAB does for this space.
Of course, no, wonderful to have you on. Okay, well, moving swiftly on, of course, as I mentioned, Women's Health Tech Wednesdays is on every Wednesday from 12:30 to 1 p.m. We are looking, of course, actively for folks that want to participate not only on the Women's Health Tech Wednesdays, but also the Women's Health Tech Initiative in general. So please do check out the links that are being put into the chat to get involved in Women's Health Tech Wednesdays and the Women's Health Tech Initiative to help drive the movement that we have for improving and identifying and addressing the unmet needs for women's health in the industry right now. And it's still me on. So I've got the pleasure of moving from Elizabeth, who is working in venture, to working with Dr. Bujri, founder of the Upper East Side Cardiology, and really talking to someone really deep within technology and helping really at the grassroots, both as a physician and also a technologist. So Dr. Bujri, thanks so much for making the time to come on our program today. I really appreciate that you're super busy. So love the fact that you've taken a couple of minutes just to talk about the work that you're doing, and also about the technology to enhance the patient care, and of course make sure we're sustainable and boosting revenue as well. So I'd love to invite you to talk to the audience for a quick 60 seconds or so and let them know about who you are and what you're currently doing.
Well, thanks for having me on. Well, I founded Upper East Side Cardiology more as a reboot to traditional healthcare and traditional doctor-patient relationships, which really fell off the cliff in the early 2000s as big healthcare took over, and the way reimbursement models unfortunately caused the doctor-patient relationship to kind of fall through. And especially after COVID, the utilization of technology has resulted in a lot more engagement, empowerment, and enrollment of patients back to the physician and resuming appropriate health prevention, treatment, and diagnoses. And to that point, the foundation of my practice and its growth and scale over the past 4 years has really been based on innovative technology both not only in the cardiovascular realm, but also in the patient engagement, utilizing new codes as well as reimbursement data that is available to physicians, and almost shifting to what I like to call a healthcare 2.0 initiative, and bring the patient back to the doctor and having this rather than the doctor being like this and talking like that the whole time.
Mm-hmm. Yeah, no, absolutely. And I think the audience would really love to know, based on sort of the experience that you described and the work that you're doing right now, your perspective and how you envision digital technologies actually transforming the patient care within healthcare organizations. And if you can give us any examples of sort of specific digital tools and platforms that you may have come across that have actually been successful in improving these outcomes and experiences.
Yeah, absolutely. With the new coding system by CMS guidelines, the adoption of telehealth and telemedicine and beyond, really has allowed me to take care of my patients in a virtually real-time basis. Yes, in person, but also while they are at home. A clear example of that is something called home-based cardiac rehab or virtual rehab, and the company that I utilize is called Recovery Plus. And RecoveryPlus.health is a fantastic home-based cardiac rehab technology-based platform. Now, just to step back a little bit, I'm not only a cardiologist, but I'm a survivor of heart failure. In 2015, my heart stopped, and I'm I am currently taking every medicine I prescribe. But out of all the medicines that I actually have taken, cardiac rehabilitation or guided exercise therapy and nutrition that is reimbursable has been better than any pill I've ever taken to improve my heart health and my patient's heart health. Its adoption, however, really fell through the cracks prior to new CMS changes in the utilization of telehealth and remote patient monitoring. Now, companies such as, and really in the forefront, Recovery Plus, I'm able to write a prescription for home-based cardiac rehab. So my patients who can't make it to the Upper East Side or are unable to or cannot go to a gym physically can utilize this platform and have guided exercise therapy for their heart health, nutrition, as well as real-time physiologic data that is sent to me, and real-time assessments that may or may not need emergent or urgent care by me. That is not only beneficial to the patients who cannot or unable to come to the Upper East Side, allows us to interact with them in a real-time basis, have continual engagement so we don't lose the patients, prevent rehospitalizations. In fact, studies have shown a huge decline in rehospitalizations as it relates to heart failure. And finally, excellent reimbursement, complete adoption from CMS and private insurers, because after the public health emergency, what we saw and what studies have seen and are continuing to see is that this works. And as both a patient and a cardiologist, I'm living testament to really providing virtual cardiac rehab or home-based cardiac rehab to any and all patients. And it's a win-win. I mean, look, we're in this profession to save lives and to continue to save lives, and this has elevated that statistically and on a personal basis and anecdotally on my patient population. But it also allows a great stream of income, both because of the reimbursability of it in remote patient monitoring, in physiological monitoring, in monthly updates, and allows continuity of cardiovascular health and no dropout rates in the retention of patients.
No, that's really, really fantastic. And I think you've been on one of the panels before at one of our previous programs with Recovery Plus, and really spoke to the audience about, that importance for the ongoing rehabilitation, when it comes to those who come through an episode like yourself. Thanks so much for sharing the story as well with us. And we're glad that you've been able to survive and be able to tell the tale, and also really make a change, of course, within the ecosystem and with the work that you're doing, of course, as well. And I see Stan popping back on. I'm so sorry, we always seem to run out of time, but it's really wonderful to hear about the work you're doing and about the story of how you come to do what you're doing today, Dr. Bujri. And we hope to have you back, of course, on the program again. And those of you in the audience, please do connect with Dr. Bujri and find out more about the work that he's doing, both with Upper East Side Cardiology, of course, and as well as Recovery Plus as well, who I know are great partners for both Dr. Bujri as well as HITLAB.
Thank you.
Thanks so much. Stan, back to you.
Fantastic interview, Jerry. Thank you for doing that. And again, we are really excited to see practices like what Dr. Bujri is doing in terms of really taking the virtual healthcare model by storm and really helping patients all over New York City by expanding accessibility the way he has. On that note, we're jumping straight into our next session and really excited to have Dr. Essel on with our own Ainsley Bowen, excuse me, to discuss some very important components of pediatric nutrition and food as medicine from one of the nation's leading health plans, Elements Healthcare. And on that note, we'll hand it over to Ainsley. Ainsley?
Thank you so much for being with us today, Dr. Kofi. It would be so great for you to give a quick introduction to our audience.
Awesome. Thank you all for having me. My name is Dr. Kofi Essel. I'm a community pediatrician by training, and I'm the Food as Medicine Program Director at Elevance Health.
Awesome. Thank you again so much for your time today and taking out of your busy schedule. As we know, March is National Nutrition Month. So I wanted to ask you if you could share your journey as a pediatrician and how your focus on nutrition evolved in your career, particularly with the focus on pediatric patients.
Great question. So it's interesting, when I started doing work in this space, I've always been interested in food and nutrition. And when I got to medical school, I always thought I would have to put my interest in food and nutrition to the side. Why? Because doctors don't really do work in food and nutrition. That's what I was always told. Well, I looked at the research and it was clear. There was not a big emphasis on food and nutrition in medical training. Years ago, 1985, groundbreaking report from the National Academy said, hey, we need to incorporate more nutrition education into medical training. And years later, we learned that it still hasn't been done. So this was something that we had to kind of go out and seek after, finding opportunities and mentors who are focused in food and nutrition space. And I had to really sit under them and learn from them how I could then incorporate this into medicine. Years later, as I chose to go down a track in pediatrics, I started to really enjoy this space and try to figure out what the best lane is for me to take this career path. And initially, when you started to see work done in this space around food and nutrition, in children in particular, everything was focused on obesity, right? Obesity prevention, obesity management, obesity solutions. And this was an important aspect, but it didn't tell the whole story. Why is that? Well, obesity is far more complex than I had been led to believe years ago, right? Obesity is a complex, multi-system chronic disease that requires a multidisciplinary approach. The simplistic approaches that we were using with calories in versus out were not really addressing the condition and wasn't really meeting families where they were and recognizing the incredible stigma we were bringing into the care of our patients and families. What happened through my journey was I started to learn a lot about what I would call social drivers of health or health-related social needs, especially around food and nutrition. And one of these social drivers of health that I started to learn a lot about was food insecurity. Food insecurity really started to help me understand and open up my eyes about how I could use food and nutrition in a much more effective way in meeting members or patients rather, where they were with different populations that I was serving, whether Medicaid or commercial insurance. And so in thinking about food insecurity and engaging it, I started to understand the prevalence was incredibly high. I started to realize that I had my own experiences, and I started to realize that it not only affected disease outcomes of patients, but it also affected how they engage with food. right? So food insecurity, it sort of affected the stresses of families, and they started to gravitate towards foods that are more ultra processed and more convenient and lower nutritional value, higher in caloric density. There were all these challenges that they were having around picking foods. And also food means so much to people. It's not only health, food is social, food is pleasing, food is family, food is joy. Food means so much to us. What I started to do as a pediatrician was really lean into the space of advocacy. So advocacy in a few different fronts. I wanted to help providers and myself screen better to address health-related social needs, so food insecurity, nutrition security. And then not only that, but intervene to connect families to meaningful resources that were local, federal resources that would be incredibly helpful to them in their journey towards improving health. But the last thing that I started to advocate around was really using my voice, learning that I had a voice, learning that this voice mattered in different spaces, and hearing the stories and the experiences of my families, and taking those stories to influence big P policy and little p policy within organizations to improve health outcomes, recognizing that these roles were things that I could do as a pediatrician were very important for me and really helped lead me into the steps, into the positions, and the things that I'm doing today.
Well, I think that's a great journey and great explanation for why you are and what you're doing today. And definitely as a pediatrician, I feel like, you know, you can use your voice and be an advocate for all of your patients. So I think that's a really great and enlightening journey that you're embarking on. And I'm glad you get to do something that you are really interested in within nutrition. And also tell me more about your food as medicine strategy and how this integration will impact healthcare outcomes from a payer perspective.
Great. So as you all know, I work at Elevance Health. For those who don't know, Elevance Health previously was known as Anthem. Elevance Health serves over 47 million members around the country. And one of the things that I think is really important to understand is that being in the food space is not new for Elevance Health. This is not a new thing. For years, we've been doing a lot of work within the food space, within commercial lines of business, Medicaid and Medicare, within our own house account. So we've done a lot of really great work over the years in this space before I even got here. What I will say is about 3 years ago, our foundation was working on a number of different opportunities around the country. And one of the things that they realized is, hey, what would it look like if we streamlined our services to focusing on 3 main areas? Maternal health, substance abuse, and food as medicine. So food as medicine became a priority area, and they started committing larger amounts of resources towards that to support communities throughout the country in improving health outcomes. What we saw as a result of that was improved health outcomes. In addition, our own house account, our own employees started to benefit from some of the programs we were offering, which provided medically tailored groceries. We were seeing improvements in ED visits and improvements in health outcomes. And we said, what does it look like to create better alignment across our enterprise? So we created the position of Food as Medicine Program Director and allowed for better alignment to be created overall. Our strategy has been an effort that we've spent a lot of time really focusing on, and I would love to share some of that with you all today. When we think about our strategy, there are a few different elements that we think about. We have 3 pillars that we focus on. Focus number 1 is how do we implement food as medicine as part of our health strategy within our whole health paradigm. You might have heard about whole health before, but the way we think about whole health is we recognize that the health of our members around the country and patients has a lot more to do with what happens outside of the 4 walls of the clinical spaces than within the 4 walls of the clinical spaces. I hate to say that as a pediatrician, but the reality is it's true. So much happens outside of those 4 walls. Food insecurity, nutrition insecurity, housing, transportation, all these factors are huge. And we heavily lead into these concepts when we create solutions for families, recognizing that we have to uniquely understand these experiences and then be able to respond in a unique fashion as well to be able to meet members where they are, no matter where they are. So that's important for us. So the first thing we want to do is implement a food as medicine health strategy within our whole health strategy, right? So we think about this through every line of business: commercial, Medicaid, Medicare, our house account within for our own employees. How can we think about food as medicine to fit within this whole picture? It's going to look a little different, but that's an important aspect for us to create better alignment. Number 2, we really focus on advancing a digital-first approach to food access and education. So we recognize the role of great solutions that lean into digital-first solutions right? And we want to make sure we're building this around food access so all of our members can access high quality foods no matter where they are, so that they can live an active and healthy lifestyle, in addition to high quality education as well. This is really important for us, and we are using digital first approaches to do this. And last but not least, number 3, what we're trying to do is advocate. We want to advocate to improve health systems and to really build awareness for the role that food plays with health. We want to bring these worlds together, advocate for these things. So you'll find us in many different circles. One, we really want to prioritize thought leadership, right? Leading in the ways that we're talking about this and moving forward data and talking about this in many different forms and fashion. We want to make sure that you see that we're working with a lot of our community partners on the ground who've been doing this work for years, that we value and cherish in this work that we're doing. And last but not least, we want to support public advocacy and public policy that move this work forward. Some of the public policy that we even think about is even thinking about things like the medical loss ratio. We want to recognize that how can social drivers of health not be viewed as an administrative service, but rather a medical expense? We recognize that when CMS and the federal government put some clarity around some of these initiatives, it only allows organizations like ours to scale up these initiatives. We're going to do them anyway, but it allows us to do it even better. And so we look forward to that as well. So those are our 3 pillars. And on top of our pillars, we're using a number of different approaches, from medically tailored meals to medically tailored groceries or medically supportive meals and groceries, to produce prescriptions, to federal nutrition programs, aligning well with those, recognizing that they're effective, they're evidence-based, they improve health outcomes, from population, community level healthy food policies and programs, again, policies and organizations, the communities that are doing great work as is. And last but not least, we want to support personalized and empathetic nutrition counseling and education, meeting members where they are, tailoring education for their needs to support them in improving their health outcomes. These are some of the areas that we are focused on and we're really prioritizing through our food as medicine health strategy.
Yeah, I think you really, really well defined that how food as medicine is a strategy in everything that you just said. And in talking about how it's evidence-based, how do you measure the success of the food as medicine interventions, and what metrics or outcomes are prioritized when you're evaluating their effectiveness?
Thank you for asking that question. I don't think we can ask that enough. I think we have to not forget about that. We've gained and garnered a ton of momentum in this food as medicine space over these past few years. And it's going to be so important that we're able to continue to show how these programs are improving outcomes in a variety of different ways. There's some basic questions that we still ask, right? So what's the right dose for food as medicine? How much food do we need to give? For how long? For what is the best medication or right foods? What foods should we be using for certain conditions? How long should we be using them? Should we be combining initiatives? There's still questions that we have, but we also know there's a lot that we already know. We know the effect of food on disease outcomes. We know the effect of education on disease outcomes. We know when we bring these 2 worlds together, there's a synergistic effect that we can see. We are not waiting for all the questions to be answered before we lean into this space, because at Elevance Health, we truly believe in the power of food as medicine and want to give it the chance it deserves. So how do we measure these things well? There are a few ways that we would think about. First and foremost, when you think about outcomes, we want to think about the health outcomes of individuals. What's happening with diabetes and high blood pressure and maternal health outcomes and all these conditions? Our A1C is improving, our blood pressure is improving. What about maternal health outcomes, birth outcomes, right? What about overall mental health status? We also want to think about health-related social needs. What about food and nutrition security? How well are those being improved as a result of these interventions? We know that these can be improved. How well are they being improved? We also want to think about cost of care. We see the skyrocketing rates of healthcare over the years. The Rockefeller Foundation and Tufts University did an analysis a few years ago looking at the cost of diet-related chronic conditions and food security on our healthcare system. And they tabulated that it costs us over $1 trillion annually. So we know that costs are going up. Can food be used as a way to curb costs? Let's think about it. ER visits, reducing ER visits, reducing hospitalization or readmissions to the hospital due to malnutrition and other concerns. We want to think about medication adherence. Some meds are going to be critically important for improving health outcomes. Can we use food as a tool to improve medication adherence? What about hospital or clinic visits, primary care and specialty visits? These are all the ways that we want to think about as well. There are a few other areas that I would highlight. One of them being using food as an engagement tool. Can food be used as a tool to improve connectivity with patients and families? This is an important way that we can measure and see as well. And last but not least, we don't talk enough about this, but we want to understand the qualitative feedback about these interventions as well. Qualitative research has always been important to me and the work that we've done. And how we think about that, we want to ask members directly, how has this been beneficial for you? And how can we improve upon these experiences for what you are experiencing on a day-to-day basis? Are foods tasty? Are they convenient? Are they effective in helping you reach your outcomes? Do you enjoy them? Are you eating these foods? These kind of things are important as well and are important outcomes that we want to look at. And I should also mention other satisfaction metrics as well. HEDIS scores, quality metrics through CAPS and STARS. These are a variety of different tools that we want to use to understand the effectiveness of food as medicine within the spaces that we sit.
Yeah. I gotta say, after hearing all about this, I never thought about food as medicine in this way before. So I think you've really opened my mind, and I'm sure a lot of our audience here today as well, about how food really can be used as a medicine. It can, like you said, perhaps eliminate ER visits, eliminate, just general healthcare concerns. So this is a really enlightening conversation because I've never really thought about this before. And I know we're close to time, so I wanted to ask you just one more question here. Can you provide a specific example or case study even where food as medicine strategies have made a significant impact on health outcomes?
Yeah. And I want to highlight that, ED visits overall are not going to change with only food, right? We're talking about diet sensitive conditions. We're talking about the role of these conditions and how they correlate with food and nutrition security. These are ways in which it can improve. Some of the ways that we have used food as medicine within our enterprise and have seen significant outcomes. I mentioned some of them earlier, but let me be a little bit more specific. One of the groups that we've worked with, so our foundation has committed $30 million over a 3-year period to supporting authentic food as medicine solutions around the country. One of the interventions that we supported is a partnership with Feeding America. For those who don't know, Feeding America is one of the largest umbrella organizations encompassing the majority of food banks around the country. These food banks have done a phenomenal job in engaging with populations far and wide. So what we've seen is that these food banks and the support that we provided to Feeding America, what they've done is partner with a number of food banks, which have partnered with local health systems. And they've created what we call food pharmacies that are patient and member facing, not just our members, but patients around the country or individuals around the country who are experiencing chronic conditions or who are experiencing food and nutrition security. And we've seen that as a result of these interventions, these powerful collaboratives, we've seen that plenty of positive health outcomes have resulted in these as well. And we look forward to sharing more of these in the coming months. But I do want to highlight that that's one of the ways in which we've seen some positive successes from food as medicine interventions.
Thank you so much for joining us today. I have such an enlightening conversation. I've never even thought about how food could be used as medicine before this. So I just want to thank you so much for taking time out of your busy schedule to talk with us about your passion and all the great work that you're doing for your community and for all of your patients. Thank you so much again for joining us today.
Thank you for having us. We really appreciate it.
Thank you again to Dr. Kofi for that great conversation. Just really quickly, I wanted to let everyone know that we have tickets on sale for our New York City Health Innovation Week. You can click the link in the chat. If you're one of the first 100 startups, you get $2,000 off of the ticket price. And moving right along, I'm super excited for this next interview. I have Jenna Daniels with me today. She's the Vice President of Patient Success at Medable. So Jenna, I would love if you would introduce yourself to our audience.
Of course. Thank you so much. I'm actually going to share my screen if that's okay with you and just kind of walk through some slides as I feel like it'll help a little bit guide our conversation. So first and foremost, thank you so much to everyone for taking the time to listen in and learn a little bit about what I'm about to present. So as Ansley mentioned, I'm Jenna Daniels. I head up our patient and site success strategies at Medable. Medable is a global technology software as a service system that enables clinical trials to be run anywhere. So outside of the clinical setting, increasing that access, increasing the ability to include more people across the globe, and really understanding what health conditions look like outside of the clinical setting. So super excited to share a little bit more about that. So bit of a background about myself. Before joining Medable, I was a clinical research associate, then coordinator, then manager at Harvard and Stanford, specifically for kids with autism, and really trying to understand how mobile tools and technologies could help with early intervention and then diagnosis. I learned about Medable during that time and joined about 6 years ago. And the first thing that I was asked on my very first day was, what legacy do I want to be part of? Like defining my why. And so that's what I think about every single day, for every single trial, for every single opportunity I have to advocate on behalf of patients as well as sites. So my why is to make sure that everyone that is using our technology feels seen and feels supported. So we talked a lot about, Dr. Essel talked about tailoring education, and that's a perfect segue into what my role is and kind of what we learn from in these different conferences that we attend in the life sciences industry. So my why, like I said, is for our users to be able to feel seen and be part of that product prioritization and roadmap. So I get to head up our patient success team and our site success team, which just means we have a global network of advocates that we learn from directly. And our future goal for all of this is really to continue that true collaboration and deeper understanding. So let's kind of lay this all out. We know we can't have successful clinical trials without successful sites and successful engaged patients. So we went to focus on those two. And what this actually looks like holistically, like I mentioned, those patient and site networks, that global and diverse network where we can learn directly from patients and sites, they help us to prioritize our product roadmap and really think about how can we up-level that technology adoption. So thinking about standard and study specific onboarding and training, and thinking about how we can truly embed the experiences of everyone we work on behalf of into what we're doing day to day. So I know I'm going to stop sharing my screen now, but just wanted to give a little bit of a background to kind of set the stage for what we're about to talk about in our discussion.
Yeah, no, thank you so much, Jenna. And as we know, this conference is talking about the review of HIMSS and Vive. So specifically, as we strive to enhance user experience in digital health technologies for clinical trials, Vive actually emphasized the importance of seamless and user-friendly products. So can you elaborate on strategies that you believe are crucial for vendors to create products, considering the insights that were shared at Vive? And how do you envision incorporating these strategies into training and onboarding processes?
Absolutely. So the biggest thing that we learned at Vive and then at HIMSS and then also just in these other conferences is the end users, so patients, site users, the sponsors and CROs, the study builders, they all want to be involved. They all actually want to be part of the process of thinking through how to build, what to provide, and not just be told, like, here's what you've got to onboard. And so what we are doing and what I recommend to these different vendors is making sure that it's not just a check mark that you're talking to one patient or one site, because that's one experience. And we all know as medical professionals and researchers that one story is not enough. Although it's incredibly important, we need to really, truly talk to patient communities, to site networks, and understand and remember that everyone learns differently. People learn through through listening, through visuals, through doing, through reading content, and making sure that no matter what it is that you're creating, there's an opportunity for every person that learns in a certain way that's embedded. I think the most important thing too is knowing that when you're a study coordinator or when you're sitting with that patient and their family and you're onboarding them into this clinical trial, and it's in a situation where everything kind of feels out of control for them, that site coordinator, that study personnel is literally the face of the entire clinical trial. They're the face of multiple vendors. They're the face of the entire protocol. They're the face of that sponsor. And so as vendors, as the sponsor, it's our responsibility to make sure that everything is so easy to use, so easy to understand, that coordinator can focus on the relationship with that patient versus focusing on what button do I click next. So it's on the vendors to come up with that onboarding and education and training that's seamless and easy to use and quick.
Yeah, no, absolutely. And that kind of sparks another question is, the Vive conference also underscored the significance of user feedback in improving product usability and satisfaction. So how would you leverage the insights also from Vive to integrate this user feedback effectively into training, and also onboarding for digital health technologies and clinical trials?
Definitely. So one of the biggest things with sites to consider is that there's so many different types of sites, from academia to site networks to single one-offs to in all the different therapeutic areas as well. So making sure that you are in the design process or in the discovery phase of your onboarding is really focusing in on bringing a variety and diverse group of people into that process, like having them click through things, having them share how they would want to see it. What are their pain points? What are their challenges? Really have that user experience research mentality of, how might I? What would you do? Like if you were head of product for this company, what decisions would you make? And I think Vive really emphasized the ability and opportunity to consider reaching out and understanding like that people do want to get involved. People do want to share their insights. It's kind of like it's kind of like focusing on the education for vendors to inform them that these sites do want to get involved. They just need the opportunity. They need to be aware that they can.
Yeah, no, absolutely. And I know that we're running a little bit behind, so I wanted to ask you just one more quick question. Given the emphasis on innovation and emerging trends in training at Vive, how do you stay informed about the latest development in this space?
Absolutely. So honestly, through our global network, that patient caregiver network, as well as our site network council, these are patient caregiver and site advocates who have a variety of different experiences. Some who've participated in clinical trials, some who have participated in completely decentralized trials, some hybrid, some that are running studies, some that have never been eligible to participate. And so we really look to our global and diverse network of this group to help us stay up to date and informed and share their insights internally throughout the entire company, as well as attending these types of conferences, learning and attending these types of symposiums that HITLAB is hosting, and also just really making sure we're staying up to date on papers that are getting published and speaking opportunities. So thank you so much for this opportunity to share and learn more.
Well, thank you so much, Jenna, for your time today and taking time away from your schedules to speak with us today. And thank you again so much. And I'll hand it over back to Stan.
Sounds great. Thank you.
What a fantastic interview. I just learned so much about design, and obviously having done so many clinical trials over the last 30 years, even those insights were so really, really informative. So thank you, Jenna. Thank you, Ansley. And if you don't know much about women's health tech, or you are involved in women's health tech and you want to really contribute to the ecosystem more, join one of the largest networks in the world around women's health tech and venture, supporting women in their efforts to improve equity and improve technology there. And talk to us about your interest. Just email myself or LinkedIn if you want to, or Ansley certainly, as she is one of the leaders of the Women's Health Tech Initiative. And let's get you involved either as a member or a board member or whatnot. It would be phenomenal. And we go from one amazing leader in the ecosystem to another. Dr. Nathan Schlichter from Providence Healthcare is going to be talking with our own Riley Fink about what's happening in the intersection of telesocial work and AI in clinical care. Riley.
Thank you, Stan, and thank you, Dr. Schlichter. Is that correct? Did I pronounce it correct?
Pretty close, Schlichter. So
Schlichter.
Nobody gets it exactly right.
All right. Well, thanks for joining us. It's always a pleasure to have a fellow Seattleite on our program here. So we'll just have you start by giving a brief introduction and a little bit about your background.
Well, thank you so much for having me. Look forward to the conversation. I'm clinically an ER doctor. So working in the inner city here in Tacoma, the other part of the town, down from you in Seattle. And so I've worked alongside and with social workers all of my life, and also in the aspect of trying to improve care and appropriate utilization of the ER. So I very much enjoyed the last two conversations about that. But about 6-8 months ago, I joined Providence to work on the 2 projects as the chief executive of Trusana, which is our behavioral health concierge, working with our social workers to try to help keep our employees supported, as well as our patients in our clinics. And then the second piece was working on how we use technology to route patients to the right care and develop asynchronous and virtual care for our patients to meet them where they're at, so that the intersection of all needs doesn't end up in the ER with me for all things when we can't meet them in the health system or the broader social system that is unfortunately far too often failing our patients.
Yes, absolutely. And can you describe a little bit more about how you and Providence are currently leveraging telesocial work to assist primary care and virtual psychiatric programs? And specifically, what does that implementation look like in practice?
There are a number of ways that we are doing it. One is on the inpatient environment, supporting tele-inpatient psychiatry at a number of sites now across the system. I believe over 50 at this point. And Dr. Jones does an amazing job of stewarding that program so that we can bring telepsychiatry to hospitals that otherwise wouldn't have the volume to support hiring an entire psychiatric service. And that increasingly is all too common. And so these patients stay in the ER, they stay in inpatient units waiting for care. And if they could just see a psychiatrist and get their medications adjusted, get into the right therapy, we've been able to show that many are able to go home rather than having to languish waiting for the next level of care. Additionally, we've been able to leverage them, directly with our insured customers to be able to deliver care and counseling. I think most importantly is the care of our caregivers. And that's what Trusana and the behavioral health concierge has been doing, is really working to support those that are providing care in the broader health system. As an ER doctor, unfortunately, I get to see a lot of tragedy in my job, and I see what that does to my colleagues. I remember, a very tragic case of a young girl who was 7 who had unfortunately gotten into her mom's methamphetamine stash and ended up overdosing and came in dead to our ER. And our team worked to resuscitate her and bring her back temporarily, but she ended up succumbing to her disease. But equally as tragic of that was that we lost 2 of our nurses that day. They could not come back to work. They could not see a future for them. And programs like the BHC that work to help our people through those tragedies are all too important, because the things that our people see, the things that they do in all parts of healthcare, are both a blessing and a burden. And if we're not there to walk alongside them and care for them, we lose them, and far too often they lose a piece of themselves in that journey. And so leveraging our technology to meet people in a way that isn't as confrontational sometimes as coming into a specific debriefing session, or having to come to an office where they may feel stigmatized when a colleague sees them, but instead doing it from the privacy of their own home to talk to somebody about their struggles, not just at work, but maybe in their relationship with their kids, with finances. I think it is an amazing gift that we give to our caregivers, and a real piece of support that hopefully helps keep them engaged in the workforce and caring for those that we're charged with caring for at the end of the day.
Yeah, it's amazing work. And you touched on something there in terms of, maybe a lack of full-time social workers being readily available. What are you doing to bridge that gap? And can you give me maybe a successful strategy or initiative that you've put in place to really help kind of overcome that, that lack of maybe just availability of full-time social workers?
Well, I think the next big step we're working on is looking at how to integrate them back into the primary care clinics, and there have been some fits and starts in that. One of the things that we've done that's been successful is reach out directly to the health plans to be able to work with them and deliver care to their members and be able to reach them. And that's something that has grown exponentially over this last year. We've doubled the number of patient contacts a month. Because we're seeing that there's no right route. Connecting via the primary care is great. Connecting through the insurer, it works too if that gets people care at the end of the day. I think the next big evolution is really bringing that full spectrum social work care that addresses the social determinants of health that Dr. Essel touched on just a little bit ago. Is all too important. We are seeing that folks are struggling with food insecurity, as he touched on, but housing, resources, and other barriers to their overall health. And I'll be the first as an ER doc to tell you that 80% of your health is determined by the rest of the things in your life. It's not what we do to you in the ER or in medicine. So the social workers that can help engage in that process can help bring us back to the things that really drive care and really drive the outcomes of your health. Whether it's getting you active in a gym membership, whatever that may be, is all too important if we're going to really, both bend the cost curve of healthcare, but also improve the quality of life for those that we serve.
And then along those same lines, what are the biggest challenges you're facing with integrating these types of telesocial work and support systems and all of these various initiatives you're putting into place? What are the roadblocks and how do you overcome them?
Well, I think with all things in innovation, there's both the technological challenge. Healthcare is complicated, they say, and add technology to that, and it only gets more challenging. So that has been a constant struggle of new challenges of whack-a-mole, of figuring out. I thought we had a stable interface, a new web platform, and there's a new challenge that may arise. So I would say right now, the technology and integration with the complicated health system is probably one of the biggest challenges.
Yeah, we're certainly seeing that kind of across the board. It's our goal is to improve access and utilize technology, but that creates its own kind of web and difficulties. So my last question for you here is it's a two-parter. Again, thank you so much for your time and for coming in and speaking with us. The HIMSS Care piece came out, and it's all about the promise of AI in clinical care. What are your thoughts on the current state of the AI tools in supporting social work? But more importantly, how can you ensure that the future of clinical care remains centered around expertise and empathy of the human clinicians while still leveraging the potential of those AI technologies?
It's a great question. It's something I really am passionate about. Before I was a doctor, I was a lawyer, so I also look at things through the lens of risk. And I think there's a lot of promise with AI, but there's also a lot of potential risk. And that's not just from a legal standpoint, but also from a healthcare standpoint to our patients. I think that there's a lot of promise in the summative features and some of the generative features that are out there. I think the big challenge that we have to figure out is where both the responsibility for management and the recognition of the non-cognitive functions that occur in medicine that will maybe not be encoded into it. And a simple example I give is not so much on the A side, but on the virtual side. There was a case that I reviewed where a patient had come in with back pain at the ER, got a CT, did fine, and then went on to 5 subsequent virtual visits where they talked about management and pain and how they were going to deal with it. And the hard thing was that over those 5 visits, not a single person stopped and asked, "Can you walk?" Because in our normal way of thinking as clinicians, I watched you walk into the room. That's already cognitively factored in. And it's not to say it's assumed, but it's assessed. Mm-hmm. Well, if you're sitting in front of your computer, you don't know if I can stand up right now if you don't ask me. And so those kind of things that we build into assessment that are not hard-coded are not things that you can recognize always. I worry AI is going to miss if we don't teach it to do that properly, because there are a lot of things that we do on a very habitual level in clinical medicine that is not necessarily easily recognized. And so as we build these models, we need to do it in a way that makes and accounts for that kind of thinking. One of the things that I'm working on inside of Providence is a program called MedPearl that is really trying to hard code the clinician's brain and the specialist brain so that we can take that information, give it to our colleagues in primary care. But as we do that, it's thinking through not just what does the guideline say, but all of the non-cognitive, non-verbalized processes that are going through the specialist's head to help teach our clinicians how to do care safely. And so I think that's the next step is really translating the knowledge and the experience and the habit of medicine and teaching the AI to do it. Great potential, but we got to do it safely and make sure that we crawl before we walk and walk before we run.
Absolutely. Well, we really appreciate your time. And again, thanks for all that you do and all the great work. And hopefully we'll get you back on and have you share some more of your success stories. So thank you again for joining us.
Thanks for having me.
All right, Stan, back over to you.
Thank you, Riley. Just a terrific interview with one of the nation's top hospital systems, Providence Healthcare. If you are from the Northeast or the Southeast and you haven't heard of them, then you need to hear about them and need to research them. They are massive in the Northwest and really the West Coast and Alaska. So take a look at them. And again, just a wonderful interview. Thank you, Riley. Also, you should remember that your professional goals are important, not just to you, but to the ecosystem that you can help. So take a look at the BT1. We talked about it earlier today, but just a great group of folks and hundreds of people from around the world improving healthcare, medicine, and life sciences through shared perspectives, evidence, and insights. So again, BT1 would be a great place to meet up with you. We have another great BT1 session coming up next week on AI and how it's transforming health plans. In the meantime, we are in now our third hour and very excited to have with us a regular here at the Digital Health Symposium, Mr. Don Jones, JD, and Chief Digital Officer at Scripps Research in San Diego and a longtime San Diegan, along with Karen Habercross, the Chief Privacy Officer at University of Chicago Medical. And we're going to be talking to them. They're going to be talking to us today about what is going on with confidentiality. Lots of news this past month with Change Healthcare and the just the absolute hack and ransomware that we saw happen with them, and how that was just an incredible disruption in the ecosystem. But Don and Karen are going to talk a lot more about CPT codes and data integrity and privacy. And I'll hand the virtual microphone over to Don. Don.
Thank you, Stan, very, very much. And thanks for being here. And Karen, welcome. And I enjoyed chatting with you earlier this week and meeting. We had a fun chat. And we're actually going off script a little bit from the agenda. We're going to end up talking about ambient AI and privacy, and not bore people with CPT codes. So I hope everybody is happy with that. But Karen, I think you and I both saw at Vive probably 25 plus vendors selling and or pitching some form of ambient AI, most targeting what was happening in the exam room between practitioner and patient. And more recently, just in the last 10 days or so, the class organization came out and reported that 58% of all health systems are planning to roll out ambient AI in 2024, which kind of, given that while it's been worked on for a long time, it really hasn't become a thing until late 2023. I think arguably positions it as the fastest rollout of any IT we've ever seen in healthcare, potentially. So I wanted to get some thoughts from you about how you're, as an organization, beginning to think about ambient AI from a privacy point of view, and what are the top issues that are kind of on the table at this point in time?
Yeah, thanks, Don. I think that what you're beginning to hear about and what we're beginning to think about in terms of rollouts are things that might integrate with our electronic medical record system. So things such as listening in clinic visits so that physicians can spend much more time talking with our patients about what is actually happening and less time perhaps on documentation. And so in terms of the ambient AI, it would be listening in the background, performing the documentation by the AI, increasing efficiencies for the physicians. Also things like meeting assistant tools, in Zoom or Teams, where the discussion can really take place and the meeting minutes can be taken by the AI assistant. And then in both of those cases, somebody would obviously be going back and reviewing the documentation to make sure, that there's data integrity and that it's correct. Other things that we might be thinking about would be hospital at home. So whether there's an opportunity for ambient AI to be in patient homes that we can leverage from a healthcare perspective, or even patient wearables. And so from a privacy standpoint, I don't know that it's really different than the way that we think about data privacy just generally. Privacy and chief privacy officers are always worried about trust, making sure that our patients and our consumers, using that word to those patients who have not yet received care from an organization, that there's just transparency around what we're doing so that they can feel, that their data is being kept private and secure, they're receiving the correct care, but that there remains that level of trust that they've come to know and expect from us in healthcare.
Sure. Let's get in, delve into a couple of the characteristics. I'm aware of at least one company, Quantum AI, that follows a structure or an architecture where they don't keep the recordings of the ambient AI. They just output the quote unquote the summation, the EHR entries and SOAP notes, etc. Whereas others actually do keep the recordings for any number of reasons, including, for example, the ability to share the interaction with, say, caregivers, for example. I'm wondering, as you think about the privacy issues, how do you think about, or how are you thinking about going about evaluating? Would we want to go down a path where we are keeping the recordings, or would we rather go one where we're not keeping the recordings? And from a medical liability and discovery point of view, how does that weigh in?
Yeah, that's a really good question. I mean, I think there's probably no good answer one way or the other, which is really how privacy officers hedge all of their answers, I think. But, I think it really depends on the purpose and the use cases. So I think, like everything privacy related, it always has to go back to what is the use case and what is the purpose for that data. And so because of that, I don't think there can be a one single strategy. I think that in healthcare, we need to look at what is the technology doing? How are we going to use it right now? So if the only purpose is to use it right now to assist, for example, with documentation and efficiencies for the provider-patient interaction, then there may not be any reason to keep it any longer than as the time that the physician has to go back and make sure that the data is correct, the note is written correctly, that that it all makes sense, and then it's pushed to the actual medical record. However, in larger academic medical institutions, they might want to keep certain recordings, for example, for research purposes, to be able to train AI models to do bigger and better things over time. And that, again, doesn't mean that it's every AI tool that we do that with. It has to be very deliberate, and the contracting for the tool has to spell out those types of things. So if we want a vendor to delete the data right away, it has to be done in a compliant manner. So all of those things need to, I think, be accounted for. Your other question had to do with medical liability, which isn't really my area of expertise, but yes, the answer is yes to that. It does create some additional risk for the organization the longer that those recordings are kept.
I got a different question, again, in this case, related to hardware and perceptions of privacy. Some of the systems that are out there are basically built around using the phone. So that suggests a use case where the doctor walks in the room with the patient and throws their phone out on the table and says, we're going to have a conversation. I've actually done a little informal poll of about a dozen folks, and they all find that rather intimidating. So that seems like potentially a bad hardware use case. Another use case is using the microphone that's already built into the computer. That seems like that's not going to work very well because those are directional mics. And I think that's going to be problematic, is my guess. A third option would be using a omnidirectional microsystem, more along the lines of an Alexa or something like that in the room, or maybe in the ceiling. And I'm just wondering, how would you go about thinking of that from the patient's perspective of privacy in terms of hardware selection? But even more importantly, at least two of the people I interviewed raised the question that says, I've actually asked the doctor if I could record the session, and the doctor said no. Now the tables are reversing on the doctors, and so it's an interesting twist on the privacy question.
I think that's a fair point on the patients. I think most of the time, recording is not something that's typically allowed. However, this is changing the table, so I think that's a very fair point. I think it really starts again. I mean, these things always start in my mind with engaging with your privacy professional at your institution early on. So before you even contract something, that you have a discussion, several discussions actually, about what does this look like as you roll this out. And then you can begin to think about, Don, all of those things related to, you know, the buzzwords these days, privacy and security by design, and all of the technical specifications. I really like the idea of this idea of trust and transparency. So how are we informing patients, usually both in writing and before they get to the room, about what we're trying to do here? And so that could involve a number of things. That could involve mass communication in advance, that, you know, the organization is about to roll out something similar to this. And, you know, here is how we're thinking about it as a health system. But letting them know and letting them have the ability to say yes or no, I think is very key. But it also means explaining it to patients in a way that they understand, which is usually somewhere around a 5th grade level. And so I think that's really important for us, is to get that buy-in early on. In terms of the use of actual technologies, I think that really just depends on the system itself and how it's set up. I mean, you're trying at this point, right, to increase efficiency and time, and roll things out, as you said, fairly quickly. So if you have to change your entire infrastructure for this, I'm not sure that that really meets the efficiency scales.
Doesn't that work both ways? You can imagine the AI being applied to the answer to questions. Is the nurse in the room or the MA in the room doing their job correctly or completely? Is the doctor doing their job correctly and completely? So in other words, it may not be entirely about the patient's privacy. It may actually be about the employee and or the professional privacy as well, in terms of their concept of privacy, as opposed to, say, medical appropriateness, completeness, and just an organizational efficiency application.
I think that's right. And I think we focused a lot, yes, the discussion a lot around patients, but yes, those types of transparency and trust and consent documents apply to employees as well.
Yeah, I would think so. I think what I've observed is a lot of physicians are jumping up and down saying, yeah, bring on the ambient AI. I really want it. I want that time back. They haven't really thought through all the downstream consequences of where this is likely to lead. I think most of it's going to be good in the terms of helping them practice better, more completely, etc. But it can actually start turning into even an HR application. One application I've recently read is ambient AI in the OR, which is really analyzing how the team is interacting together. Going towards, I mean, the aspically to look at OR efficiency, but you could also imagine it finding some poor practices as well.
No, I think that's right. I think, you know, one thing to think about too, especially in the OR, is this concept of teams, right? And so who are the best teams that work together? So are there employees who work best, or staff that work best with certain other employees or other physicians? And, you know, what do those teams look like in terms of OR scheduling, and how can that also be looked at? And so I think that goes back to this issue where we were talking about how long should recordings be held, right? Because those might be the kinds of reasons you might want to keep certain types of recordings for quality improvement or research purposes.
One of the potentially controversial areas that we may see use pop up, but it actually may have some very strong benefits as well, is the notion that companies in the pharmaceutical industry, the medical device industry, who've never had a presence in the exam room would like to have at least a summation of what goes on. How are their products, services, therapeutics, diagnostics presented? How are the patient reactions to those? Obviously leading to changes in maybe marketing and advertising campaigns, but also potentially into product changes as well over time. But that's an interest that we've already seen expressed, is other parties, third parties' interest in what's going on behind those closed doors. How do you kind of think, how are you going to be thinking about that?
Yeah, I mean, so you're asking a privacy officer. So for my first response to that is, those are the types of things that I like to limit in an organization, right? I mean, especially because sometimes that's very sensitive information that's being asked for. And so when it's possible to limit or minimize the amount of data that might be available to a third party for some other reason, or even to your own marketing teams, those kinds of things need to be thought of in advance, how it can actually be used. And you also need to be able to tell your patients in things like, for example, your notice of privacy practices, how data could be used. And this is just one other form of regulated data. And so it needs to follow those same parameters. I'm not saying that it's always a no. I mean, we want to try to get to yes, because we all want to be able to help patients, and things that can do that are important.
I think we can both come up with a long list of things that are both positive and negative about that situation. One of the practical things is your CFO may be saying yes, but if we allow that in, the system's going to be cost less or be free, and as a result, that could have huge economic consequences as well. So I have one last question as we come up to you, and it's a little bit tongue in cheek, but it's very topical today, and that is, how much do you think Kate Middleton's or Joe Biden's ambient AI conversation is worth?
Oh, wow. I don't know. That's a good question. So I have to choose between the two?
Well, I don't know. You can take it anywhere you want.
I think it's both pretty bad, I would say. I think, but I think that one thing as a privacy officer also to say is that I'm not exactly convinced that one patient's information is more important than another. They just seem to be more high profile and known.
I think the Daily Mail might actually be willing to put a price tag on, at least to Kate's sake.
Sure, that's true. I'm sure that's true.
Well, thank you very, very much, Karen. I enjoyed meeting you earlier this week, and thank you for engaging me on how privacy officers are thinking about ambient AI.
Very good. Thank you so much for having me. Pleasure.
That's great, Don. Thank you very much, Don. Thanks, Karen, for a terrific conversation about what is happening in digital health and what's happening around privacy and data sharing and so many good topics. We can keep talking about that as well. Don't forget to join us on Wednesdays. Every Wednesday from 12:30 to 1 p.m. Eastern Daylight Time, we've got the Women's Health Tech Wednesdays, featuring women who are leading the revolution in women's health tech and venture around the country and around the world. Again, click on the QR code. This is also free, and it's also a lot of fun to see who's actually leading this change in healthcare. And next up, we are really excited to finish off this last hour of the March Symposium. And we're going to be leading off with and finishing up actually with Riley's sessions today. HITLAB's own Riley Fink, one of our innovation managers on the strategy side of our practice, is going to interview one of the folks who are leading the digital transformation in the Northwest. And looking forward to hearing how that's going and hearing more about what Riley is going to be talking about with Tamra in navigating generational differences in the modern workplace. And I'll, with that, hand it over to Riley Fink. Riley.
Thank you, Stan. I will be our Pacific Northwest correspondent for the day. Tamra, you're in Olympia, is that correct?
That is correct.
Excellent. And I spoke with Dr. Schlicker, who was in Tacoma, and I'm in Seattle. So always good to have some folks from the Pacific Northwest sharing their insights. So thanks for joining us. And let's just start by having you give a introduction to yourself and a little bit about your background.
Yeah, so my name is Tamara Ryman. I am the Chief of Digital Healthcare at PSW, formerly known as Physicians of Southwest Washington. My organization, it was an independent physician association formed back in 1995. by a lot of independents in our current market area or our current county, I would say. Since then, we have expanded our growth significantly. We've partnered with a large hospital organization, Multicare Health Systems, and we are really focused on population health and value-based care, which is really not what this topic is about. But I just recently attended Vive and had some epiphanies on the workforce that I wanted to share today. So,
well, we'll take whatever perspective you want to give us today, and maybe we can have you back on a future date and dive into some other topics. But certainly, yeah, thanks for kicking it off. So how do, those values and communication styles of different generations impact workplace dynamics, and what strategies can organizations implement to, make a more collaborative work environment, especially among those multi-generational teams?
Yeah, so I'm going to just sort of go through the different generations that are in the workforce currently
Perfect.
today. And again, I do want to throw out that disclaimer. This is not my information. I didn't do the market research. I am just repeating some of the things that I have learned because I felt like they were really good for me to consider as I am bringing on new folks into my department and to my organization. So we have about 4 different generations that are currently in our workforce today. We have the baby boomers, we have Gen X, the millennials, and Gen Z. Baby boomers, really, their focus is on their work ethic. They're extremely independent and self-assertive. They are career focused, so they're goal oriented. They also tend to view themselves through their career. So how successful they've been in their career is how successful they are personally. They often prioritize work over personal life, which I think falls into, I'm not a baby boomer, but I probably straddle a little bit there. And so I see that in myself with Gen X. And then their communication preferences are really the face-to-face communication. They would rather have face-to-face or at least a phone conversation as their preference. Then Generation X, which I will admit that would be me. We were part of the first group that saw technology. I think we had Atari when I was in my younger years. And
great system.
Yeah. And we've seen a lot of different socio-political changes. We also are very hard workers, and it says that we're pretty good on emphasizing a work-life balance, but I would say that depending on where you fall into the realm of what Generation X is defined as 1965 through 1980 as your birth range, I think that you sort of fall into 2 different groups there. We are hyper independent. I would agree with that. We're pretty flexible learning new systems. We're not, I remember in my earlier years working in my previous position, we had people who they wanted their manuals, and you were going to have to peel those manuals out of their cold dead fingers. But I'd say that the Gen X is capable of implementing technology within the work that they do. Millennials are the next group, and they are very, very much about communication and inclusion. They value that personalized and frequent communication, and they like to emphasize diversity, inclusion, and teamwork. They like flexibility. They want the remote work options. And they're very much about professional growth. They like to actively seek different things to enhance their professional growth, I guess is what I would say. Their communication style is very collaborative and inclusive. So they want to have communication where it is, the team collaborating and the open dialogue between all. And they also want to make sure that there's no group that has preferential treatment or unfair advantage over another. they like words and communication. They've got a different verbal and written impact. It's an art to them. So that's a very good description of it. And then they expect some HR role in fostering that inclusive communication. They want their HR team to be participatory in that and directive. And then Gen Z, which is our newest generation moving into the work environment, they grew up in the digital age. So when they were born, they had digital at their fingertips from the beginning. And they want meaningful work that aligns with their personal driven values. And they also are big on work-life integration, making sure that it's not taking over from your personal life, or your work life isn't driving everything. And they're very much about prioritizing social impact and sustainability. When you talk about their communication style, they like informal and quick. I think one of the things that I heard at Vibe that was very enlightening to me was, if you want to capture a Gen Z attention, you've got about 8 seconds to do so, which I thought was
Wow.
not something that I would have known. And for some of these folks, this would be my youngest child. He went through COVID, so for at least a year, and for him it was more like 2 of his school years. It was all done digitally and remotely, and so he's sort of grown up in where that actually works for him, and some other folks may not be able to work in that same way. So that was a lot. Sorry.
Yeah, no, that's great. Thank you for sharing that. And just from your perspective, looking at the broad spectrum of preferences and values, where do you see technology kind of fitting in there? And you certainly talked about how some generations are kind of immersed in it, some are more easily able to adopt it or change, and then maybe there's some unwillingness or difficulty with adjusting. How do you see that digital age kind of playing out in a workforce so diverse as it is today?
I think there's a few things. So I think for some of our older generations who aren't as technically inclined, we need to really be able to provide education and training that allows them to understand. My husband and I work in the technology space, so I have a little more on top of my husband. But when thinking about him, and today he had an actual physician appointment online, and getting him to understand how to get that set up and making sure that he had the right instructions so that he was on time. And, if he's not 15 minutes early, he's late. So he wants to be there on time. So some of that, and providing those instructions that are step-by-step with guidance to help support folks who aren't just using that user interface and figuring it out, I think is important. And then going down to what I just said about the 8 seconds to attract somebody. If I'm out looking for a new employee, well, what I got from that is when I am pushing out my job description or my advertisement for my position, I need to be able to capture them in that first 8 seconds through some sort of engagement that is a little different than I think we've done it in the past. We like to write long, drawn out job descriptions, and here's what the job entitles, but I need to make it more of an advertisement or marketing ploy that is quick and to the point to get that attention. So
yeah, definitely capture them in the first sentence. Don't put the most important piece at the end of a paragraph. And then how do you balance from your perspective, just looking at the workforce and available job applications or people applying? I mean, you can't really take age into consideration necessarily that much, but are you thinking about, okay, what team are they going to be on? What's the kind of age differences? I mean, how does that play in your current role and what you do?
well, actually, what I'm learning. So first, I want to be very transparent. Again, like I said, I think that what I learned is something that I am going to start implementing within my department, my organization. But I think one of the big things that I'm not sure there is that digital divide, or there's that divide in communication styles. And so we've got to account for that. But what we're what we don't do a really good job of is what does each of these generations bring to the table? I think that is something that we should focus a little bit more on and recognize that collaboration piece that brings a lot of value. So where I would go with that is when you think about your baby boomers, they have that institutional knowledge that likely the other generations don't bring. And when you think about your Gen Z, or just going from the oldest to the youngest, they have that innovation, that they have different expectations on how things should work and how they approach doing their job. And if you bring the institutional knowledge, everything in between with the other generations, and that innovation and that digital awareness and that digital greatness that comes with the Generation Z together, like what we can do to solve for administration and administrative expenses, what we can do to smooth out some of the workflows that are in place from a technology standpoint today. I think we have a lot of opportunity there. But what we've got to do is get through that communication piece and make sure that we're communicating with the right generations the right way to capture them.
Yeah,
Which
absolutely.
means it's multi-channel, right? You got to do
Yeah.
it in multi-channel.
You can almost think about it as, a learned sharing space where people, have different work experiences, but maybe also different kind of values and generational preferences, and they can help teach the other person the best way for communications or innovation, or in ways to utilize technology, and kind of create a more cohesive, collaborative experience. So that's great insight. Thank you very much for sharing. Unfortunately, that's it for our time today, but would love to have you back on, and if anyone wants to, they can connect with you and LinkedIn and through channels, and hopefully we'll get some sunshine here pretty soon. Who knows?
Yeah, appreciate your time. Thank you.
Alrighty, thanks. Back to you, Stan.
That's great. And thank you, Riley. And again, just an incredible representation from the Northwest today. We always love that. Lots of innovation happening in the Northwest since the very beginning of really digital health and medicine, going back many decades, including healthcare delivery. Group Health of Puget Sound was one of the first direct contracting staff model HMOs out there. And they were also really just extraordinary in terms of implementing digital, one of the first ones, that large scale health systems to implement an electronic health record system. So hats off, and just great to hear that the innovations keeping up. If you know of any speakers, or if you know of any topics or technologies, I just popped in my LinkedIn channel link, if you will, into the chat box. Please connect with me and let me know what you want to hear. We run these innovation sessions, we run these digital health evidence symposia every month, and we do like to hear from our audience and hear what you want to hear about, whether it's AI, or whether it's more about what happened with Change Healthcare, or whether it's about privacy and a lot of the topics that we're talking about, or something that's more topical on that month like women's health or whatnot. So definitely keep us in mind. We'll also be sending out an email with more feedback, and that if you could respond to that, that would be really helpful. Next up is one of our regulars here at the lab, Zina Manji, one of the big regulatory experts in digital health and healthcare and life sciences. And she's here to go into some more detail and really treat a topic that's important in healthcare, particularly this month, which is really talking about transforming healthcare through digital lifestyles. So we've talked about nutrition, we've talked about different kind of behavioral components. We had the head of food as medicine from Elevance, one of the nation's top health plans. And now we're going to look at it from another one of the nation's top health plans, which is California Blue. And so with that note, I'll hand it over to Zina, and take it away, Zina.
Thanks so much, Stan. Yeah, really pleased to be here and on this symposium. Certainly, how we empower ourselves for better health is a big topic here, and areas that we have more control over. Our nutrition, our lifestyle. And so I am so pleased to have with me today Angie Kalasek Ibrahimi. She's Senior Director of Lifestyle Medicine at Blue. And what a intriguing topic. So I'm so looking forward to learning more about lifestyle medicine. And Angie, if you could talk about your role and what lifestyle medicine is, and what you do as being head of that department.
Absolutely. And I think it's interesting to hear that a health plan has a department called lifestyle medicine. And so I feel very honored and grateful to be a part of the work that we do at Blue Shield of California in the lifestyle medicine space. And so people always ask me, well, what is lifestyle medicine and why does Blue Shield have this department? Why is it important? There are hundreds and thousands of clinical studies that show how lifestyle has the power not only to prevent, but also to treat and reverse chronic conditions. And we look especially across kind of the whole range of cardiometabolic conditions that are so prevalent in our society today, and trying to get to the heart of like, what is the most clinically effective, cost-effective treatment that's out there, and also one that all of the side effects are positive, right? So really that is what lifestyle medicine is. We have a suite of digital care solutions that are lifestyle based. We started our platform, which is called Wellvolution, and we primarily started in the cardiometabolic space. So diabetes prevention was kind of the cornerstone, kind of how we set it up. We added diabetes treatment and reversal, heart disease, hypertension, obesity management. And then as we kind of moved forward, we realized we also wanted to include things like mental health. So we have mental health digital apps on the platform that people can either do alone or pair with the work they're doing in cardiometabolic. We recently added musculoskeletal solutions, and we also, of course, sort of table stakes have a tobacco cessation program for our members.
That's amazing, Angie. And I think what I'm gathering here is you're really approaching this from a holistic standpoint, because there are so many core morbidities that happen with these cardiometabolic conditions. Looking at one or a couple independently is probably not treating or looking at the individual as a whole. And I think that it sounds like the angle of lifestyle medicine is also looking at not just the drug, not just the numbers, but actually the person and how they're living their life. So could you talk more about Wellvolution and how these programs are offered in that regard, and how patients or individuals through this program from Blue even become aware of what to choose and how to select?
Yeah, absolutely. So from the get-go, when a member of Blue Shield of California goes to Wellvolution, they are asked a series of questions. And those questions, they drive at things like, first of all, what are your health needs? What kind of conditions are you looking to treat and reverse? And then what are your health, what's your health history? And then what are your health preferences? Like, do you prefer a Mediterranean diet or are you a vegetarian? Would your lifestyle be conducive to a keto diet, depending on if you're trying to look at type 2 diabetes? So we really try to understand who that person is and what can work for them. And based on that, we then recommend one of the digital solutions that's in the platform. The member still has the choice, the freedom to make a different choice than we recommend. But it really, I think most people do go with that recommended option because it really kind of helps them get started. Once they're in that program, it is highly personalized. So even if you go into the solution that is Mediterranean or keto or fill in the blank, each of the programs that we offer has a health coach that spends time with that member, gets to know what is working for them. Many of them have wireless remote devices that are attached, so weight scales, glucometers, some are measuring ketones, blood pressure cuffs. So they're seeing the data come back in, and based on, hey, it looks like you aren't doing so well with some of these recommendations, let's switch it up, let's try this and that. In addition, exercise, this is the kind of the nutrition component, but exercise is a key and critical component of any kind of cardiometabolic program. It not only does it help with weight loss or driving to better outcomes, but it also makes you stronger and feel sort of more energized. And I think that kind of propagates success for our members. And then, of course, the mental health aspect. So all of the programs that we offer have a mental health component. So the health coach is checking in saying like, how are you doing? And there's content on the different program sites that allow people to go and read more about how they can meditate. And they can also select our mental health options on Wellvolution and do both, right? Do them side by side. So there's a lot of ways that we are trying to get at the whole person.
Incredible, Angie. And when individuals are looking at the programs, is it up to them in terms of can they choose how in the level of engagement they feel comfortable with? And also in terms of health outcomes, how do you look at data and whether the evidence is actually showing that there is improvement in health outcomes? Can you talk a little bit more about that as well?
Absolutely. It's interesting that you bring up engagement because we have very clearly seen that the members who are highly engaged usually hit the best outcomes. And we are tracking outcomes. I mentioned that we have these wireless devices. So depending on the condition that the person is addressing, let's just use weight loss as an example, they'll get a wireless scale. And so we are getting those results back from the individual members and then in aggregate. So we are seeing fantastic results. If you think about people who start diets, what percentage of people actually are successful on those quote unquote diets? Very few, right? People go on, they go off, they yo-yo up and down. We're getting 25 to 30% of the people that are engaging in these programs hitting clinically significant outcomes. And for the ones that are highly engaged, they're hitting like 65% of them are hitting outcomes. So this is a really important distinction. The more sort of a dose response, the more that you're engaged, the better you're going to do. I think this is one of the reasons I love my job so much is that seeing people actually succeed. I think that there's a lot of naysayers out there that are like, well, lifestyle change is hard. It's a lot easier to just prescribe a medication, but when a member goes through a change in lifestyle, it's not just the condition that's going away. Their whole life is changing. So we get these testimonials from our members that are like, thank you, Wellvolution, thank you, Blue Shield of California. You've really changed my life. Not only am I no longer a diabetic, but I can run and play with my grandkids. I enjoy my life more. I have more energy. I'm traveling. I'm not in pain. I mean, there's so much. I'm sleeping better. My sex life is better. I mean, all of these things that go along with being a happy, healthy person from lifestyle. So again, yes, it's very gratifying and we're seeing some terrific results.
I can totally resonate with what you're saying in terms of patients and people trying to improve their life, having a family that has some of these cardiometabolic conditions. I think we focus so much on weight and not actually all of the other benefits that are coming. It's not just about the weight loss. That's only one real aspect. I like to think about the side effects of weight loss being the other benefits that are really coming. And I think that can help to drive inspiration to keep the habits, to really, it's not about how you look. Looking better is a benefit, but it's really about what's happening inside and also how you're living your life. So that's pretty good, very good data that you're sharing there on the engagement side. I think one thing, there's such an epidemic of obesity, and we see all the GLP-1 medications that are out there. How have you been seeing that coming into play with patients and how they are managing their conditions with these types of drugs that are needed for certain population, but also it comes with caution?
Yeah, it's a very complex topic. So I think what I'll say about these are like the GLP-1 medications that are now kind of all the craze. Ozempic, which is a useful medication for people with type 2 diabetes. But then the off-brand Wegovy for people who are trying to address obesity. There are some significant costs, as you say, from taking these medications. One of them that is quite significant, it is sarcopenia or muscle loss. So we're starting to see that people who are on these medications are losing sort of more muscle than they even would lose on a diet. And whenever you're losing body weight, some of that will be muscle. That's normal, but it's very, very important to manage that, right? We don't want your muscle mass to decrease to the extent that you go into your senior elder years with frailty, right? And I think that's one of the things that I worry about a lot with the GLP-1 medications. We are providing another option for our members that are using these drugs, which is Wellvolution. So we actually ask our members to do 6 months of a weight management program before approving a weight loss medication. So many times people don't go on to take the medication because they found another way, a better way to address their weight loss. And even those that do go on to take the medication to kind of finish their journey, the programs that we offer are helping them safely get off of the medication, because this is another cost, quote unquote, that we're seeing is that people get off the medication, they gain all the weight back. So to have that partner to help them move through that transition of getting off the med, but keeping their weight in a healthy place.
That's fantastic. You've addressed some of the barriers and call to actions here in terms of lifestyle medicine, and really looking at that first as a first option, and actually can result in some solutions before taking some other measures. So thank you so much, Angie. I'm sure this conversation and what you've shared has inspired a lot of people to relook at their health in different ways and introducing lifestyle medicine as a treatment choice. Thank you so much.
Thank you, Zena. Pleasure to be here.
Back to you, Stan.
No, that's fantastic, Zena. And thank you, Zena, for, again, another amazing interview like you do every month here at the Symposium. So thank you, Zena. And we are rounding into our final 15 minutes of our 3-hour symposium this month and talking about all the different things that are happening in healthcare, in digital healthcare, that we've learned not only just from Vive and from HIMSS, but also from the fact that it's an extraordinary year for women's health tech. And our next guests. And by the way, don't forget, quickly here, the New York City Health Innovation Week. New York City Health Innovation Week is Nietzsche, NYC, HIW, and not just a German philosopher anymore. Nietzsche is, imagine JP Morgan Health coming to New York City every year, the second week of May, before tourist season kicks in and after April showers and the holidays. So that's what Nietzsche is going to be. And it's going to start this year already with over a dozen events, from the HITLAB Summit to the eLab Competition Day to the Merck Design Studios afternoon, and a whole slew of cocktail hours being hosted by everybody from Salesforce to a variety of other groups like NYU Biolabs and a number of other groups. So we were just really excited to have a large ecosystem from Columbia, Cornell, Mount Sinai, NYU, and just a host of other groups hosting that. So do try to make it if you can. And like I said, we're just wrapping up here with Helene Rutledge and Roisin Sasson to talk about what they've been doing with BirthView. And as you know, BirthView is one of the leading women's healthcare companies out there today that are developing technologies for not just prepartum, but also actual at the point of delivery care, and then also postpartum care. So with that, excited to have BirthView with us here today. Helene and Roisin, welcome.
Hi, Stan. Pleasure to be here today.
Hi, Stan. Thank you.
So if you could give us just an update on where things are and how things are going with BirthView today.
I have to let Helene take this one.
Great. Yeah. So we're really excited to share that we did research with HITLAB, and that is publishing right now. And we also have Rashane's algorithm, which has the capability to do simulations. So the exciting part about that is that where with de-identified data, we can prove even more that the algorithm can optimize births that have already happened, as well as the prospective pilot partners that will benefit from this solution for labor and delivery.
That's great. And again, I think, a huge amount of the audience watching today, and certainly that'll watch this on demand, is Health Tech. The Women's Health Tech Initiative at HITLAB is obviously one of the largest networks in the world when it comes to supporting women in health tech and venture to develop women's health products. And if you could as well, talk a little bit about some of the core issues that you're seeing with women's health and birth view, and how it's working. And is birth view really more than just about the point of delivery and reproductive care there?
Absolutely. And I'll start and then Rashane jump in. But one of the things that is really a focus, especially during Women's Health Month, is that women's health is about more than just reproductive issues. And of course, BirthView starts with the birth event and optimizing labor and delivery. But addressing women's health comprehensively knows that in those issues, this has the potential to impact life well beyond that. Because women who experience severe morbidity or near-death experiences then have these ongoing effects, both physically and psychologically, for the rest of their lives, which impacts healthcare costs and quality of life.
That's great. Roshane?
Yeah, absolutely. And in totality, we've come to understand that addressing maternal health outcomes and inequities is not only a moral imperative that we all as human beings have to take part in, because we all know someone who has gone through childbirth and experience unfavorable outcomes. So this is something that we all need to put our foot forward to try and achieve. And we also understand that America is a melting pot. When looking at disparities and inequities, we understand that, as America's population grows, the amount of people this will affect is going to drastically rise as well. So this is something that we especially have to address, including severe maternal morbidity, which Helene mentioned. And, although this happens throughout pregnancy, or it could happen during labor and delivery, the effects last much, much longer than this. It could last up to a child's 5th birthday, 7th birthday. So we're looking at complications increasing significantly that show signs that they need to be addressed.
Let's build on that if we could, Helene, to talk a little bit about that. It sounds like you both are driven by a passion to improve women's healthcare at the point of delivery. What are some of the compelling reasons that drove this mission that are driving the creation and development and scaling of BirthView?
So a lot of it is that inequity, and really the shocking fact that America is of all the developed nations in the world, we are the last in terms of infant mortality. And the inequities for women of color show that they're twice as likely to lose a baby and 3 times more likely to die in childbirth. So we believe that through technology and really digitizing best practices, that we can increase access to quality healthcare to women across the country in all different types of places, including those healthcare deserts where women just don't have the resources or the ability to deliver safely.
Yeah, and that's an amazing statistic. That's a stunningly horrendous statistic, really. And we've been hearing that. It's not something new, by the way, right? We've heard that for, since I was in grad school, 30 years ago. And so it's nothing new at all. And it's just been getting worse, which is even more amazing. But Roshane, let's dive into the weeds a little bit. Talk a little bit about how the platform is actually improving outcomes. Again, you're a computer science whiz out of Penn State. You've got an amazing background in development and programming and architecture. What is it that the actual platform is doing to improve outcomes?
So to improve outcomes, essentially the platform is empowering patients with labor insights right by their side. Many times patients tend to go into childbirth and relinquish a lot of their rights. So the solution is, in a sense, helping foster and build upon that. We take uterine pressure strength data, fetal heart rate data, which a lot of current monitors use to track patient information. And our algorithm reads this information to try to find efficiencies during contractions. We look at intensities, we look at strain, and our algorithm is able to pinpoint areas that women need to accomplish to maximize their performance while not creating too much strain to lead to potentially other complications. So this is how we're helping improve these outcomes. We're helping them maximize their performance, and our AI-based solutions are giving them a toolkit to help support natural birth, to help guide them through their labor progressions and let them know, just because you're 10 hours into this as a first-time mom doesn't mean there are any signs leading to a C-section. You're doing great, and all the statistics are there to help foster reassurance.
That's fantastic. I mean, that really is the right way to go with this. And, just to build on that, Helene, obviously something like this takes a lot of partnerships. It takes a lot of alliances. It takes a village to raise a child. It takes an ecosystem to raise a startup. And so when you think about that, what is it that you need, Helene, to build BirthView, to scale it to millions of moms, not just in the US, but around the world?
Sure, yes. So data is essential. So one of the things that we're looking for is partnerships to have de-identified data sources to expand the training set. We're also looking to have smaller practices for user testing. So we know that the solution has already been designed with doctor and patient input, but the more like hands-on users that we have, the better that we can optimize. And we're also looking to partner with device suppliers because we want the platform to be fully interoperable, which will make it more versatile for different settings. And of course, throughout the whole process, we're having clinician and patient input so that we continue to learn and iterate as we scale.
That's fantastic. Well, look, if there's anyone in the audience, you are all connected now. And we've just popped your LinkedIn connections into the chat box as well. If there's anyone in the audience that can help BirthView get to the next level, please link in with both of these folks and let's get everyone connected so we can improve and certainly the outcomes for maternal care at the point of delivery as soon as possible through BirthView. Thank you both for joining us today. And again, we'll look forward to hearing from you, certainly at the summit coming up in New York City at Nietzsche and in future months on the Symposia. Take care.
Great. Thank you. Bye.
Bye.
And that rounds out our last set of interviews for the day for the March Symposium 2024. Just a reminder, one more time, for those of you who weren't here earlier, we want to make sure that we have as many of the HITLAB community entering the Age Tech Collaborative from AARP Challenge coming up this June. Remember that applications are open for only a few more weeks, and so we want to get as many folks in there as possible. So just go to hitlab.org/AARP-challenge to enter your company or your friend's company as soon as possible. Also, just really excited to see everything coming together when we look at all of the different companies we heard from today. And certainly just an incredible confluence of digital, of healthcare, of medicine, of life sciences, improving patient care around the country and around the world, certainly winding up with BirthView. Clearly, the funding environment is improving. It's not great. It's not 2021, 2020 at all, but it is getting better. And we're hearing from the panelists and the speakers today that the angels are writing checks. We're hearing that the funds are doing more funding, that we're seeing customers move, not jumping in with both feet necessarily, but they're definitely moving fast. We did hear about the number of hospitals that are 67% are planning on launching major AI initiatives this year. So we do know that in certain pockets, one person actually said that this is the year of women's health. And so if you start looking at the tea leaves in front of us here, we do see substantial funding and substantial movement, particularly in areas like women's health and AI. And so again, along with our partners here today, thank you to the Merck Global Fund, Helix VM, the unicorn taking off out of New Jersey in telemedicine, Metadata, FFF Enterprises, the world's leader in intelligent packaging, IMC, Information Media Corporation, CanView, our partner with Data Science Challenges, and certainly the Age Tech Collaborative from AARP, our partner in Challenges for the Aging. And so obviously we have an amazing team that puts this together every week. So hats off, round of applause for Rachel, Yamita, Ainsley, Raymond, Pallavi, Melissa, Jerry, Naomi. Thank them profusely, because without them, we wouldn't have a program, we wouldn't have speakers, we wouldn't have all of this production, and certainly we wouldn't have the folks that actually know about it because of all the work they do to get the word out. So thank you, team, for putting together such an amazing program, the best team in digital health by far. And we look forward to seeing you at the end of April and hopefully seeing you on site at Microsoft Tech Center at the beginning of May. Take care, everybody. Stay safe.